distinguished speakers. It's a great pleasure for me to moderate this session, which is a very special session, talking about special experience in the life. It's probably outside our scope of medicine. It's more than presenting an experience of getting a special life style. And our speaker is my dear, can I say, my dear son, Omar Al-Alfi. خير سلف لخير أو خير خلف لخير سلف. Omar is a graduate of Ain Shams in year 2010. He has MD MRCH, and he will talk us about his experience of impossible or as a half Ironman. So Omar, please.
It's my pleasure to be introduced by Dr. Magdi, my mentor. It's my pleasure to be here in this virtual conference. Thanks to my dad and mentor, Dr. Mohsen, for the generous invitation. My talk today will be called The Impossible, or we can say it and look at about I Am Possible. I hope you enjoy it. I have been interested in the triathlon and in the Ironman competitions for the past 3 years. The Ironman competition, it consists of 3 sports: swimming for 4K, cycling 180K, and running for 42K. I'm still half Ironman. Hopefully, I was going to do the Barcelona this year. Because of the COVID situation and some financial issues, it's have been postponed for later. When I look at this distance 2 years ago, it was shocking to me how someone can have the ability to do such a huge distance, and for what? It was been a question concerning me. It was been a dream. First time I've done it in Dubai, 2018. It was awesome. I enjoyed it so much. Then I begin to think, is it a challenge? Is it a challenge? It's a huge challenge. And actually, I was inspired by this man. One of my inspirations was this man. He's called Barry Hardy. He is a hemophilia patient. A patient who bleeds in his joints, a patient who has clotting problems, have been cycling all over America with his bike, and he's a hemophilia patient. I thought if this magician have done it, I should try to do it. The hemophilia patients years ago have been discouraged to do sports, have been discouraged to engage in running in physical sports because of the risk of bleeding. Of course, this affects their psychology, affects their health. Years later, the concern about hemophilia and sports have been changed a lot. In 2020, a study has proven that sport participation was similar across severities and injury rate among the hemophilia patient and general population. And this is a breakthrough. And in 2018, the sports medicine in a team in Germany have successfully managed an athlete with hemophilia to win a lot of competitions in a contact sport. In Netherlands, where my heart goes, they use prophylaxis regularly for the hemophilia patient as a standard treatment to help them to engage in sports daily. They start the prophylaxis at the age before the age of 3 years, and they teach the parents and the kid how to give the treatment for themselves so they can be independent. Actually, when we hear this, we think of the song, the Egyptian song, El Dunya Rabi' wal Jaw Badi', as it's called. It's very perfect. It's very dreamy. It's very optimum. Is this achievable? Actually, there is a huge concern about that. Why? Because, of course, it costs. Everything has a cost. On average, the low dose prophylaxis yearly for this patient, low dose prophylaxis, ranges from 75 to 300,000 pounds. And of course, no regular sport participation without prophylactic treatment. I have COVID now. When I think that I have a health issue that prevent me to go to the club and play my usual sport, it hurts me. This year has been tough financially on all of us, of course, because of the COVID, and I had some extra concerns about the financial issues. I have been struggling, and I felt so down, depressed a lot of times, actually up till now. But my struggles were for luxury stuff. I want to change my bike. I want to travel. When I was preparing this lecture or talk, it hurted me a lot. How come a father for a patient, a kid, his dream to play squash, to run, to play football, he is avoided to do that. And then his kid, I imagined his kid on the mobile or the net playing, and he tell his dad, I have read that, I've Googled that other kids can do what I can do. Why I can't do that? There is a drug that can help me to be like a normal person. Why I can't do that? It hurted me a lot, feeling the same situation about the health and about the financial concern. It puts a lot of responsibility among our shoulders to talk for these people, to make their voice reach all over Egypt and all over the world. It's a huge responsibility. Can we do that? It's a responsibility on the medical companies, the pharmaceutical companies. It's a responsibility among us doctors, among us athletes, to give a focus on these people and how we can help them to reach their goal or dream, to be normal, not to get a new bike or to travel abroad. Actually, I was talking with Mrs. Amani. I was talking with a lot of sports team here in Egypt. I'm thinking to prepare an event so we can run and we can show here in Egypt and all over the world with a lot of different ideas. It's coming a lot through my mind. And actually, I was going to initiate a run or maybe a series of events. It's called Run for Those Who Will. And actually, I was giving it the name first, Run for Those Who Can't, but it hurted me. The name I felt it tough. No, they will, inshallah. From this place, I hope we can do something special for those people, for those kids, for the parents of these kids. They feel they can have normal life, to engage in sports, to do what they were not able to do. And those people, those kids, those beautiful kids, will be able to engage, to enjoy, and to have a normal life. I hope you have enjoyed my short talk. I hope you had a good time. I'm pleased with this invitation. Thank you so much.
Thank you so much, Omar. I mean, this is a very touching presentation, and you reflected on your experience on how others are suffering and our responsibility to to try to help them to at least, as you say, make their life close to normal life, and hopefully in the future to become completely normal. So I think we have like 5 minutes. If anyone would like to ask Omar any questions or any comments, please do.
Yes,
Yeah, I have a question for. Yes, go ahead, Professor Gary.
Yeah, please.
Just comment, because I have seen this. You know, my son is living in Newcastle, and every year they prepare for a marathon, and this marathon is graded according to age, meaning that the younger the age, he can go through 100 meters, for example, and the older he goes for 20 kilometers, and so on and so forth. But every one of them is wearing a shirt, and this shirt is dedicated to someone. For example, if you are wearing this for hemophilia, so he is wearing like hemophilia icon or whatever. But all this needs a good collaboration between societies and the government and the people. It's not as simple as you are showing, but it is definitely of value. So if you can prepare such a campaign, this will be marvelous. It's not only for them to run, but for those who are giving them the push and giving them the money and help them in prophylaxis, so they can do it the next year. So what you are preparing now is a long-term campaign. It's not only today, it's not only once, it should be continuous, and starting from the very beginning with regulations and with campaign, and then go on with
Professor Gary,
Thank you.
Omar already joined many marathons for Magdi Yaoub, for cancer children. He did already. But
Yes.
now he's speaking for the hemophilia community. And
Yes.
Omar, if you could tell us what's half Ironman, then maybe Mrs. Amani, when she will come in her talk, she will tell us what about the full Iron Woman. What's half
Mohsen, if you
Ironman?
allow me, I would like to offer that together with Espho and the Egyptian Hemophilia Society, we collaborate with Omar to prepare such an event.
Yes, very good.
He was just telling me, and I discussed this with Professor Magdi this morning. Hemophilia Day is only one day in the whole year. I believe if it is April, a whole month for hemophilia, and maybe one day every month for the hemophilia community, at least to support them. It is a long journey. I saw myself in Melbourne, in Australia, and I was with Elikiabi in Melbourne 5 years ago for the World Federation of Hemophilia. The champion of judo in Malaysia is hemophilia. He was 16 and accidentally looked like the San Francisco tram. And he introduced himself to me, and he started to chat with me. He give himself the shot every day to practice. But every day is not that problem. A diabetic patient, they receive 3 injections, but sub-Q. This is intravenous, but he becomes expert to give himself every day for so many years. His mother is giving him a support. So Omar, tell us what's half Ironman.
A half Ironman, it's a competition, consists of swimming for 2K, cycling for 90K, then running for 21K.
Mm-hmm.
I have done
in
Dubai
a time or open? In a special
time average of a maximum 8 hours, 8.5 hours maximum.
Mm.
Okay, and you did it in Sal Hashish also?
Yes.
Or Sal Hashish was not a competition?
Actually, this year it's going in Egypt. The first time to have half Ironman, the official competition in November, inshallah.
So, Mohsen, I think we are now, we have to close the session to start the CSL bearing session, if you allow us. Thank you very much, Omar, for this very
Thank you, Omar.
insightful presentation, and we should cooperate with you to the.
Inshallah. Thank you, Dr. Magdi. It's my pleasure.
Thank you very much. Now, can we start now, Mohsen, for the? I don't know, Muhammad, if. Dr. Mohsen.
الكامبين دي لازم تبقى على مستوى المدارس كمان يا دكتور مجدي.
ان شاء الله يعني we can
مش الاثليتس I mean كل الناس الصغير وكبير يعني.
ان شاء الله ان شاء الله باذن الله. هو بس رمضان كابس علينا، لو نقدر نعملها بعد رمضان يبقى كويس قوي ان شاء الله.
يا خديجة فين؟
Did you hear me?
يا فندم.
Now I can hear you. Can we start now?
Yes, I am trying. Is it shown up or not?
Not yet.
It's on the way.
The screen is shown up?
Not yet, Prof. Not yet.
Not yet. Okay. Maybe I'll try back. Yes, I think it will work.
Oh no, it's done.
Did it show up?
It's coming.
It show up?
Not yet, but
Not yet, dear.
not yet.
Also not yet?
Not yet, Prof.
Not yet?
Not yet.
I'll start from the very beginning. Okay.
Yes, yes.
It says that you are sharing the screen, but it doesn't show.
Okay. 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 I'll try again. It is locked, but I'll.
On your ease, Prof. Nice seeing you. On your ease. Hi, Dr. Ikebi. Hi.
Okay.
Okay.
It's coming. We have a nice moderator helping the speakers who are doing their best to. Is it shown up or not yet?
No.
Also,
Not yet, dear.
your
Not
internet
yet.
connection is unstable.
I think, Doctor,
Okay, so
just wait.
I'll go inside.
Doctor, it said like it's being sharing, so we could just wait for a few seconds. It will show up.
أنا هاجي هنا.
ممكن يكون النت ضعيفة شوية محسن.
هي كده برضو أنا هعمل نفس.
هي البرزنتيشن مش عند محمد يقدر يشارك؟
دكتور مجدي حضرتك بتكلمني؟
بقول لك انت مش عندك البرزنتيشن.
عايز اشير
لو كانت البرزنتيشن بتاعت الدكتور محسن عندك يشارك.
مش عندي ديت، لا
مش عندك. اوكي.
وحضرتك بعتها لي بالايميل.
اديني بس ثانية كده.
اتفضل.
لو عندي كنت هشيرها على طول.
مفيش كده برضو؟
لا يا دكتور محسن لسه.
أنا مش لاقي أي تفسير الحقيقة.
Professor Mohsen, you can take 1 minute to just send it to the email of me or Mr. Gafi, and we can share it immediately.
هو مفيش مشكلة في الشيرنج يا دكتور، يعني ممكن أي حد يشير. طب ممكن أي حد يجرب تاني؟
معلش.
It is start now.
حضرتك بتكليك على شير سكرين.
طبعا
هي بتشير
هي
بس
غالبا النت ضعيف.
دبل كليك تو انتر فول سكرين مود. حضرتك لما بتشير بيطلع لك ويندو ثانيه، الويندو الثانيه بتختار منها اللي هو البرزنتيشن نفسها.
ما انا مختار البرزنتيشن، بس هي عامله كروس كده زي الصليب لما باجي هو نيو شير.
يعني حضرتك ما تخليهاش في الفول مود الاول، يعني خليها في
ما انا مش عاملها في الفول مود، ما انت عارف.
لا ما
يعني انا معلش ان شاء الله تتحل. جون انا هدخل من اول وجديد.
Following the presentation of Professor Alfi, we would have a hemophilia session with distinguished speakers, Professor Ikiebi, Professor Roseanne Qadir from UK, talking about women health troubles suffering from bleeding tendencies.
كده السكرين ظهرت ولا لا برضه؟
لسه يا دكتور محسن معلش.
ظهرت
يا بيه، ظهرت.
اوكي.
نبتدي يا محسن.
The whole story that we are speaking about sports, so I should show the walking machine behind me, but it doesn't belong to me, it belongs to Omar's mother. So it is not me, I didn't use it. So I am sorry for this inconvenience. No. My talk is about ITI for the Egyptians with inhibitors, the problem and how to solve it. This is the Ain Shams headquarters. It was a palace in the past. I have no conflict in the first part of ITI. In the second part, I will give a resume on the variate safety and efficacy for the hemophilia community. The agenda, 7 topics. The royal family of Queen Victoria II. She has Albert, he was hemophilia, and he became the head of the army for a long time before he died a little bit earlier. Maybe he died in the late 30s or early 40s. This is an old slide, maybe dating 5-6 years ago, but I guess the diagnosed number of hemophilia in Egypt is around 6,000. This is the role of factor 8. Factor 8 is the factor missing for hemophilia A, and it is the key player in the blood coagulation cascade. So if it is absent, when there is a vessel damage, the tissue factor binds to factor 7, becomes 7A, stimulates 10 to be 10A. With the presence of factor 9 and 8, they call the prothrombin complex, turn the prothrombin to thrombin. The thrombin generation generates the intrinsic mechanism with more involvement of factor 8. If factor 8 is missing, the clot either doesn't occur if in severe cases, or it takes very long time to develop, and the patient bleeds for a long time in the joints and in the tissues and in the muscles. The risk for inhibitor development. This is the key slide in my presentation. Patient genetics, tell everything. How tall, how happy, how everything. So for hemophilia severity, severe hemophilia A, they develop inhibitors in 30 to 40%, while mild 5 to 8%. Because the severe hemophilia, most of the mutations are high-risk mutations. Factor 8 mutations will come in the next slide. Also, the polymorphism in immune regulatory genes play an important role, and it was one of the secondary objectives in CEPIT trial, but they didn't show the results up till now. Positive family history. Patient environment, patient genetics, and treatment given. Patient environment, the intensive exposure to treatment. So all the time, we shouldn't give intensive treatment. Immunization, surgery, and infection plays some role. The pattern of treatment, therapeutic regimen giving, and if there is surgery early in life at the first exposure, like circumcision, 4-fold higher risk of inhibitor. What are the consequences of inhibitor development? Arthropathy, bleeding control, bad bleeding control, and poor quality of life. They suffer a lot. Hemophilia A patients, they suffer. Hemophilia A with inhibitors, they suffer a lot. It is in the range of 25 to 35%. Maybe in the Egyptian population, hemophilia population under treatment, it is in the range of 15-20%. They become resistant to factor VIII replacement therapy and may lead to an increased risk of severe bleeding, arthropathies, morbidity, and also mortality, especially from internal bleeding on the top intracranial hemorrhage. The genetic risk stratification in the CPIT trial. CPIT trial, 8 important publications come out from the CPIT trial. On the top is the one in the New England Journal 2016. But this important also presentation in the Blood 4 years ago by Rosendal from Netherlands. He is a statistician and hemophilia also caregiver. The survey of the inhibitors in plasma product exposed toddlers, and that's the name CPIT comes from. It is a survey of the inhibitors in plasma product exposed toddlers, showed a higher risk of inhibitor development with recombinant factor VIII compared to plasma derived, with a risk of 1.8 risk factor. We investigated whether risk stratification by factor VIII mutation identifies patients who do not suffer this deleterious effect of recombinant factor VIII. However, out of the 235 randomized patients, almost 200 with null mutations were classified as high risk. So most of the hemophilia A are at high risk to develop inhibitors unless we are very cautious. No a large amount of treatment at one time, no surgery at the start of treatment of hemophilia patients. Prophylaxis is better than episodic treatment, because on prophylaxis you give one dose every 2 to 3 days, but in episodic sometimes you need to give 4 or 5 doses, especially if the patient presents late. Only 38 out of 235 with non-null mutations were classified as low risk for factor VIII inhibitor development. Egypt shares with 95 patients in the CPIT trial. 35 out of the 95, that's to say 37% of pups, they develop factor VIII inhibitors. 40% were in version 22 mutation. And Professor Naveen Tawadros, who is carrying the moderation of this session, was one of the team doing the CPIT trial. In version 22 is a major cause of severe hemophilia A in Iraqi Kurdish, like in Egypt, like in Palestine. And another study by Professor Sharif, prevalence of factor VIII inhibitors among version 22 mutation subgroups. In version 22, there were 27 out of almost 115 patients. That's to say 22% having inversion positive, 22 positive, and the inhibitor was around 30%. While in the group with inversion 22 negative, the inhibitor development was 15% only. So inversion 22 positive at definitely double risk the inversion 22 negative. According to the most recent World Federation of Hemophilia guidelines last year, 3rd edition, we have to initiate ITI when it is diagnosed. And we should be all the time aware, if the patient shows no response to treatment and you are not following factor VIII inhibitor by Bethesda unit regularly, you have to think that this patient developed inhibitors, especially in the first 50 exposure days. Low dose prophylaxis is the standard of care of the treatment of ITI in our region, where we cannot afford the high dose. The low dose plasma-derived factor VIII enriched with von Willebrand factor complex might be effective as ITI therapy in inhibitor-positive severe hemophilia A patients with high titer inhibitors. Why we call them refractory or difficult to treat because high titer delay in the start of treatment. So delay of start of ITI is a high risk for response. Annual cost of ITI in a study published this year from Thailand, that the cost of episodic treatment costs around $30,000, while the ITI, successful ITI, costs around $55,000. However, only episodic treatments was paid by the government budget by passing agent, whether this is Novo7 or fiber. The European principles of inhibitor management, early recognition and accurate diagnosis of patients developing inhibitors remains of high importance. It is recommended for patients with inhibitors to have their inhibitor titer checked regularly, either every 4 exposure days in the first 50 days, or every 6 or every 10. So I guess every 10 exposure days for the first 50 days may be mandatory. And you suspect development of inhibitors when you find poor response to your treatment. And it should be done. It should be done before any invasive procedure. Appropriate assay of inhibitor detection and quantification should be used. A panel of outcome measurements to compare therapies, including both joint physical examination. We all do this. Imaging, now ultrasound and MRI, and in the past X-ray, is a central importance. Patient-reported outcome, pain intensity and interference, the quality of life, health quality of life, and activities and participation. And this all about why we think that a half Ironman and Iron Woman should be our guest speakers, because involvement in activities and participation of sports of our hemophilia A patients is a goal. Someone will ask me, we cannot find sometimes episodic treatment for hemophilia A, and now you are speaking about activities and sports. They deserve that. And maybe 20 years before the Hemophilia Society becomes more active with the MOH to find out money for these hemophilia patients, the consumption was like 0.1 unit per million population. Now, I guess we exceed 1 unit. So maybe the consumption in the near future will reach 100 million international units per year. This is the ITI, low-dose immune tolerance induction therapy in severe hemophilia A children with high titer inhibitors. These are my co-authors. The aim is to assess the effectiveness of low-dose ITI, time to achieve response. The response after 6 months or 9 months or 12 or after 1 year, the response rates, 50%, 60%, 80%, and the rate of annual bleeding, joint bleeding during the period of treatment and the year after, and the absence from school. It is a prospective single-arm study on children with severe hemophilia A with factor VIII less than 1%, previously treated with factor VIII having poor risk status for ITI treatment success, which means delay in the treatment and high titer antibody. Inclusion criteria: severe hemophilia A, aged between 2 and 18, high titer, that's to say more than 10 Bethesda units, delay in the ITI initiation for more than 2 months, and willing to receive ITI. Exclusion criteria: recent ITI treatment and presence of transient factor VIII inhibitors. The low dose is 50 international units per kg, 3 times a week. High dose, 200 international units, 4 times the cost and 4 times exposure. Some of the protocols are daily, some are 3 times a week. We adopt the low dose, which is 50 international unit per kg, plasma-derived enriched with 1 Willebrand factor complex concentrate 3 times a week. Time to achieve response, total or partial response were analyzed, annual bleeding rate, number of target joints, factor VIII recovery, school attendance. 20 patients, and 20 patients is a small study, But since ITI is not very popular because we believe it costs a lot, this idea should be changed. Whenever you find patient with inhibitors, you have to try to treat him as early as possible. It may be short treatment, maybe 9 to 12 months with low dose 50 international unit 3 times a week, 50 international unit per kg. Age was 3 to 12, pre-inhibitor level 36, enrolled and followed up for up to 2 years. Duration of ITI was less than 24 months. Early toleration, that's to say early response in 60% of patients. Analysis of the patient success was 60%, partial response percent. Complete response means besides the unit less than 0.6 for like 3 months. Partial success between less than 5 and more than 0.6. Annual bleeding rate was reduced after ITI treatment markedly to half. School attendance improved by 60%. A low number of target joints was observed immediately after ITI versus pre-ITI period, 50% reduction. In those with successful ITI, the median factor VIII recovery was 90%, ranging from 60 to 100%. This is the table I will not bother you with. This after ITI. And the conclusion for this Egyptian ITI study, this is the biggest study in the region. In Tunisia, they have 4 to 6 patients. In Lebanon, 6 to 8 patients. In Gulf, they have 10 patients. And Faisal said we will, and Emna and Claudia and Professor Ekiabi, that we try to collect the data and we may publish like 40 or 50 patients for the Hemnet region. It will be prestigious. Low-dose ITI treatment strategy using plasma-derived factor VIII, 1 variant factor concentrate, achieved satisfactory response rate, 60% complete response, 20% partial response. Reduce annual bleeds by 60%, improve school attendance by 60%, children with inhibitor positive, severe hemophilia A, poor risk status for ITI treatment success. Take-home message, the real-world data will be used to negotiate with the MOH and with the government to increase the budget for hemophilia A as a whole and for the inhibitor patients specifically. Adequate bypassing agents, whether 7A or FIBA in severe episodic bleed, not just for mild bleed, or non-replacement therapy, which has a role now. I guess maybe more than 40 patients in Egypt are on non-replacement therapy, which is subcutaneous every 1 to 2 weeks, according to the dose. Include ITI in the National Hemophilia Treatment Program. A national Hemophilia consensus should be addressed. This is the Ain Shams University Hemophilia team. All the thanks for all of them. And King of Egypt, King Tut, asked you to visit him in his new palace near the pyramids. This is the first Hemnet forum in Tunisia with a lot of memories, very beautiful country. Second year was one of the best by Professor Ekiabi. Third year was only virtual, and I hope next year will be in Morocco. And I go for the Beriate, which is the CSL Behring product. Maybe not very popular to everyone, although it is very popular in Europe. In February 1990, Beriate was introduced into the market. It is a highly purified from plasma, contains mainly factor VIII and only some of 1 variant factor, which nevertheless is enough to bind and stabilize factor VIII. So if you use as factor VIII, you need only small amount of 1 variant factor to stabilize factor VIII. Beriate was the first factor VIII product stabilized and formulated without albumin. And this was considered a high achievement at that time because we know that most of the factor VIII plasma-derived and even recombinant are stabilized and formulated with albumin. So Beriate is stabilized and formulated without albumin, which has a lot of risk being in the component. Beriate has an excellent safety and tolerability. It is, as I said, 40 times high purification, 20 international unit per milligram protein, not stabilized with albumin. a high purity product purified from cryoprecipitate out of pooled plasma, small pools of healthy, well-known, well-controlled donors from Germany, Austria, Switzerland, and US. No one from UK or even staying in UK at the time of the cow mad illness. If he stayed for 1 year, he is prohibited from donation for Bariate. So Bariate, the pool of the plasma is very safe. All individual donations undergone serologic testing for GPT, hepatitis B surface antigen, anti-HCV, and anti-HIV 1 and 2. Many pools of 1,200 plasma donations are formed, undergone NAT and PCR testing for Hep A, B, C, HIV, and parvovirus, and elimination of any positive donations, and validated and computer-based systems are in place to enable effective quality assurance. So high purity is 200 international unit factor 8 per milligram protein. Content of von is low. Immunoglobulins cannot be detected. So in patients with severe immune deficiency or having problems, it could be used safely without a problem. Fibrinogen and fibronectin are below the detection level. Even the very low isoagglutinin, that's to say most manufactured batches have Combs titer anti-A or anti-B of less than 0.1 to 4. The ratio between factor 8 antigen and factor 8 coagulant activity is very close to 1. This means that every factor 8 in the molecule is biologically active. Sometimes the antigen is like 1.2 to 1 or more than 1.2 to 1. So not all the amount in the product is active or biologically active factor 8. You have to take care of that. This finding is in contrast to data of some other factor 8 products, mainly of the recombinant factor 8. Is published that recombinant factor 8 products 20% higher in antigen, more than 20% higher than the factor 8 coagulant. Viral safety today is not only a virus inactivation method, but a result of many measures to guarantee quality and safety of the product. And there is very strict global pharmacovigilance system. We summarize these measures as integrated safety system of CSL bearing. As a result of this system, we never got valid information on pathogen transmission with Bariate. These are the stages. Number 1, safety in the plasma selection, the production, pathogen elimination, and inactivation, quality control through internal quality and government controls for restriction and to allow product release, then surveillance, monitoring product safety, and in case of any suspected side effects, batch recall if necessary, and it never happened. Traditionally, CSL bearing invests much more into safety of the products than requested by the health authority. So they have requirements. CSL bearing go above these requirements. Regarding virus safety, not only the obligatory validation studies are done, but also intensive research with all types of viruses, even new viruses, West Nile virus and bird flu virus, and maybe COVID is not a problem, as most of the blood banks publications in the transfusion. Prions also cannot be transmitted through the virus safety technique used for Bariate production. Studies on the distribution of prions have shown that prion causing the new variant Jacob disease can be found in the CNS, but also in the lymphoreticular organs. This causes worries that prions might be transmitted by blood and blood products, but the measures, all these measures to make it theoretical risk, but never a practical risk. Stability of Bariate at 20 to 25 degrees after reconstitution under aseptic conditions is very important, because in major surgery, we sometimes use continuous infusion. So the stability of the product is important at the room temperature of the operating theater. Clinical experience with Bariate in several European countries, especially Germany, and we know how they are strict. Bariate is one of the leading factor 8 products since almost 20 years up till now. Several billion units have been used during this time, but there are only very few reports of some allergic and anaphylactic reactions. Development of inhibitors, much lower than the others, poor effectiveness or side effects. In addition, there is no evidence that use of bariate had ever been causing related to transmission of viruses or pathogens. Several studies on the long-term use of bariate in a great number of patients have documented a high efficacy, great safety, and excellent tolerability of the product. This comes in three concentrations, 250, 500, and 1000. This how it looks like the CSL burning product, 10 ml. So it is small infusion, not because it is high purity. In summary, bariate is one of the most used factor VIII products in several European countries since almost 20 years and more. Bariate is a highly purity factor VIII product with high specific activity. Bariate contains a small amount of intact von Willebrand factor, which is sufficient to bind and stabilize factor VIII. And published studies indicate very high stability in solution, clinical long-term studies, as well as very low level of reported side effects, and document excellent tolerability. Thank you very much. This is the Mina House Hotel, one of the famous hotels near the pyramids, and the museum is next to this hotel, where all the treasures of Egypt are in the new museum now. And thank you very much.
Thank you very much, Dr. Mohsen, for this very important presentation. And you have conducted two important jobs. One is the advocacy for ITI for patients with inhibitors. And we hope that through our collaboration and under the HIMNIC that we can start a collaborative work on the ITI. And the other point about the bariate, I have like one or two comments on the bariate. First, bariate is now the main treatment factor VIII product in the National Health Insurance since at least 3 years through the contract with the Unified Procurement Authority. And second, that the prions are no more a concern. Now the UK has lifted the ban on the plasma collected from donors born in 2000 onward. So the prion is part of the history now in the ISBT transfusion transmitted infections. We disregard now any studies about prion because it's not existing anymore. So we need to be safe. I mean, my question to you before I give a chance, like 2 or 3, do you have any preference for the type of concentrate that you would use in the ITI, whether it is a von Willebrand containing product, a purified component product, or a recombinant product?
For ITI, if it is von Willebrand enriched, will be better, maybe to start with, but bariate also could be a good choice for ITI. Maybe I prefer it for recombinant plasma products. I prefer it for recombinant for ITI. But when we finish and succeed to come to a complete recovery, patients should be put on prophylaxis better, and whether it's plasma or recombinant, because it will be history. He already exposed to so many exposure days, so the risk to develop inhibitors again is very minimal. And I think we have to close this session to start the World Federation Hemophilia session in collaboration with Espho and Al-Tubari session.
Mohsen, there was a similar question from Dr. Rasha, but you answered it. Dr. Rasha Al-Ashi was asking the preferred product for whether it is plasma derived or recombinant, but you answered the question.
Okay. You are sharing the next session, so you can.
No, you are the chair now.
No, I am not the chair of the.
I will share this.
Yes, the main hemophilia session.
Okay.
I'm the chair.
Alan, Professor Magda Racha. Professor Magda, steering the session. Yes.
No problem.
Okay.
No
So
problem.
no. We conclude the
same.
session. We conclude the session. I guess we will leave the floor for Professor Magda to introduce the co-chairs
Just to start.
and the speakers. Okay. Thank you very much.
Okay. Good evening, everybody.
Please unmute Dr. Magda. Dr. Magda, please push unmute.
صوت.
معلش. Khadija, do we have all the speakers?
Yes.
Okay, great. We will give just few seconds. Professor Magda will introduce Dr. Elikiabi. Okay, go ahead, Professor Magda.
Sorry, just because I had telephone call just in
No problem.
time. Okay. It's a great pleasure for me to attend this very successful conference. And at first, I would like to thank Dr. Mohsen El Alfi and the organizing committee for arranging this very successful Congress. And I thank Dr. Mohsen for inviting me to chair this session. With the co-chair with Dr. El-Ikiabi, Dr. Nagla Shaheen, Dr. Rasha El-Ashri. And in this session, we will have 4 eminent speakers, Professor Dr. Magdi El-Ikiabi, Professor Razan Kadir, Professor Sukesh Nair, Professor Khadija El-Tumbari, and my dear Professor Niveen Gamal. And now I would like to I have the honor to introduce Professor Dr. Magdi El-Ikiabi. He will elaborate very important topic about von Willebrand hemophilia new guidelines. And Professor Magdi El-Ikiabi, as you all know, he is an eminent hematologist, blood transfusion specialist, and he is the head of the Blood Transfusion Center in El Shabrawishi Hospital. He is an eminent hematologist, and he is a member and vice president of the Egyptian Society of Hemophilia, and he was a board member in the World Federation of Hemophilia. So, Dr. El-Ikiabi, the floor is yours. And I'm sorry for the interruption.
No, thank you very much, Dr. Magda, and thank you for this very kind introduction. I think I have a relatively difficult task to cover this new American Society of Hematology, ISTH, National Hemophilia Foundation, and World Federation of Hemophilia collaborative work on the new guidelines on the management of von Willebrand disease. So I will try to be up to the points in each of the slides of this presentation. So as we all know, the von Willebrand factor is a huge protein. It's like aircraft carrier, and it has 3 main functions. One is to mediate platelet adhesions to sites of vascular injury and to facilitate platelet aggregation, and in the meantime, to protect factor VIII from premature degradation. And based on this, one would think, how can we assess von Willebrand factor? And we are very fortunate to have Dr. Sukesh, who is an expert in the laboratory medicine in the field of hemostasis and particularly in the inherited bleeding disorders. But generally, we would like to measure the von Willebrand antigen quantitatively and to study its functions. So maybe the von Willebrand factor subendothelial platelet adhesion by studying collagen binding activity of the VWF, and the study of the platelet dependent VWF function through its interaction with the GP1B binding activity or restituting cofactor activity, and finally its protective activity or binding activity to factor VIII. So in a nutshell, von Willebrand disease results from reduced amounts or abnormal forms of von Willebrand factor in the circulation. It was first described by Eric von Willebrand, who discovered it in one of the islands near Finland of a girl that had heavy menstrual bleeding in 1926. Regarding the epidemiology of von Willebrand, it depends on diagnostic criteria. So generally, we describe von Willebrand prevalence between 100 to 100 to 1, like 1% to 1 in 10,000, and it affects both males and females. By restricting inclusion criteria to cases deserving medical attention and therapeutic or preventive interventions, largely corresponding to moderate to severe von Willebrand, the prevalence becomes 1 in 10,000, a logic assumption. Consistently, a higher frequency of the disease is reported in women due to physiological hemostatic challenges like menstruation and pregnancy. So, although if we assume that even the presenting cases of von Willebrand disease is 1 in 10,000, we should have identified a similar number to patients with hemophilia. But this is not the reality currently. As you can see from the 2018 global survey, we have 210,000 patients with hemophilia diagnosed globally, while we only have 78,000 patients with von Willebrand disease. Likewise, in our registry in Egypt in 2018, the number of cases with hemophilia was close to about more than 5,000, but we only have 583 von Willebrand disease diagnosed and registered. And this largely comes from the complexity of the disease and the variability of its presentation. And due to its different functions, we have different types of von Willebrand. We have the quantitative type and the qualitative type. Regarding the quantitative type, we have the moderate to mild deficiency, which is type 1. And we have the severe deficiency, which is the complete absence of von Willebrand factor, which is type 3. And then we have the type with increased clearance, which is called type 1C. Also, we have the acquired von Willebrand factor in several cases like lymphoproliferative disorders and others. And then we have a qualitative type, which is related to the dysfunction of the molecule itself. And with this, without going into details, it is 2A, 2B, 2M, and 2N, and the platelet type von Willebrand. The inheritance in most of the cases is autosomal dominant, except for type 3 and 2N is inherited as autosomal recessive. Presenting features include mucocutaneous bleeding, heavy menstrual bleeding, and in the severe type, maybe musculoskeletal bleeding like in hemophilia. So in 2021, recently, the ASH, ISTH, NHF, and WFH issued their new guidelines on the management and on the diagnosis. I will focus here on the management, and Dr. Sokesh will talk about the guidelines for the diagnosis. So the scoping questions for the management were about whether patients with severe von Willebrand need a continuous prophylaxis. Those with type 1 that may depend on desmopressin therapy, should we do this before we start the therapy? In patients with von Willebrand and cardiovascular disease, whether we use antiplatelet or anticoagulant therapy or not. Patients with von Willebrand disease, again, undergoing major surgery, what are the levels that we would like to target? For minor surgery, whether we target higher levels through replacement therapy or desmopressin alone, or we add tranexamic acid as another therapy, or even use tranexamic acid as a monotherapy. In women with heavy menstrual bleeding, do we rely on tranexamic acid or add also hormonal therapy and desmopressin? what are the levels of factor replacement to attain in women who would like to have neuroaxial or spinal epidural anesthesia during labor. And finally, for von Willebrand to control the postpartum hemorrhage, whether we rely on tranexamic acid or no treatment. So for prophylaxis, the recommendation was to have a continuous prophylaxis in patients with severe von Willebrand, which is mainly due to recurrent musculoskeletal bleeding, recurrent GIT bleeding and angiodysplasia, and recurrent heavy menstrual bleeding. And we need to bear in mind, and these guidelines is addressing the standards of therapy in developed countries, and not yet addressed the therapies in the developing countries. So, I mean, they describe the prophylaxis as infusing 40 to 80 units of von Willebrand resuscitating cofactor activity. And my comment here is that this might be a high dose for us in developing countries. So in type 1 von Willebrand, if we need to infuse, can we infuse lower doses? Because these patients may already have a certain level of von Willebrand existing in their circulation. If we are using not the purified von Willebrand concentrates, but the highly concentrates, except for some concentrates that has the dose labeled, some others contain, but it is not dose labeled. So how can we prescribe the dose? This can be also another challenge. And if we do not have these concentrates, we probably may resort to virally safe cryoprecipitate as an option. Regarding this desmopressin trial, it is recommended mainly for those who have von Willebrand factor level below 30 international unit per ml. And in these patients, the panel suggested that we have to do this trial and not to start treatment without having the trial in order to make sure that it is effective. In the meantime, we need to understand that desmopressin is contraindicated in type 3 and type 2B, and it does not work properly in many types type 2. It cannot be used for patients undergoing major surgery. And although it is assumed that it can work in patients with von Willebrand level above 30%, but a trial is also can be used, it is contraindicated in patients with coronary heart disease, cerebrovascular disease, and peripheral vascular disease, and in patients with seizures disorder, patients under 2 years of age. And it can be used safely for pregnant women, and it has to be limited if we are giving infusions, because it can lead to hyponatremia. The way I will skip this slide in the interest of time, for the thromboprophylaxis, the recommendation for patients that are, cardiovascular disease who require treatment with antiplatelet agent or anticoagulant therapy, the panel suggests giving the necessary antiplatelet or anticoagulant therapy over no treatment. And it is important to reassess the bleeding risk throughout the course of the treatment. In severe cases, we may also have to give prophylaxis with von Willebrand concentrates to balance the increased bleeding tendency that can result from the anticoagulant and or antiplatelet therapy. And as we said, desmopressin will be contraindicated in this case. For the control of the von Willebrand replacement in major surgery, we have to keep, the recommendation is that we have to keep the level of von Willebrand factor, and not only factor 8 level, but also von Willebrand factor above 50 international unit per ml for at least 3 days after surgery. And the panel recommended against only using the factor 8 as a surrogate marker for the level of von Willebrand factor. So we need to measure both and to achieve this level for both factor 8 and von Willebrand factor. In patients undergoing minor surgery or minor invasive procedure, the panel suggests increasing von Willebrand factor activity levels to above 50% with or 50 international unit with desmopressin or factor concentrate with addition of tranexamic acid over raising the level alone without the tranexamic acid. And herein, we need to individualize the situation. In some surgeries, we may also resort to local measures like fibrin glue or gelatin sponges like in dental extraction and others. For the control of heavy menstrual bleeding, the panel suggests using either hormonal therapy or tranexamic acid over desmopressin to treat women with von Willebrand disease and heavy menstrual bleeding who do not wish to conceive. But if they would like to conceive, then the use of hemostatic agents will be necessary to control the bleeding. Desmopressin, as we said, will not be beneficial in type 3, and it's contraindicated in type 2. The panel encourages the development of multidisciplinary clinics in which gynecologists and hematologists see patients jointly to facilitate the management. And we will probably hear this from the experience that will be presented by Dr. Razan. For neuroaxial anesthesia during labor, they recommend keeping the level during the pre-procedure and during the existence of the procedure between 50 to 150% activity of the von Willebrand factor. The recommendation does not address the utility of the neuroaxial anesthesia because it's not in this scope. It is only how to control the hemostasis if the patient has the choice to use this type of therapy during labor to reduce the pain. We also have to assess patients for thrombotic risk post-delivery and prophylaxis. If the lady is obese or has a higher thrombotic risk due to pregnancy. Finally, the last recommendation is about the tranexamic acid, and the guideline panel suggests the use of tranexamic acid over no treatment in women with type 1 von Willebrand or low von Willebrand factor levels. And this may also apply to types 2 and 3 during the postpartum period. And the tranexamic acid may be given systematically via the oral or intravenous route. The oral dose is 25 milligram per kg, typically 1,000 to 1,300 milligram 3 times per day for 10 to 14 days or longer if blood loss remains heavy. The guideline panel will issue soon a pocket guideline for clinicians. We are working on it and hope to come with it soon, that it can be helpful for both diagnosis and management guidelines. And thank you very much. I hope that I did not go over my time for a long period. Thank you very much.
Thank you, Professor El-Ekiabi. Thank you. Thank you, Professor El-Ekiabi.
My pleasure, Dr. Rash.
This amazing presentation and these recommendations is all new. And now I have the pleasure.
Hello?
Hello?
Hi, can you see my screen?
Yes, dear Professor Razan. Yes, dear.
I have the pleasure to represent Professor Razan Abdelkadir. She's our upcoming star. She's an eminent professor and consultant of obstetrician and gynecologist at the Royal Free Hospital at London. She one of our friends. We are usually meet her during our meeting abroad, and she is the editor of the Inherited Bleeding Disorder in Women book, and she is going to tell us about a common issue in some inherited bleeding disorders in women. Hello, Razan. Can you hear us?
Thank you so much.
Hi, Razan. And Professor Khalid Al-Hudaybi is with us. He is a professor and the head of the OBG Gynae in the co-chairs. So we will enjoy your talk, Razan. Go ahead.
Thank you so much for inviting. It's so lovely to see you all. Although virtually, I would have really preferred to be in Cairo physically, but hopefully next time. So I'm going to talk about women issues, and I thought I will give you a brief history of in relation to women and bleeding disorders, and what are the impacts and the magnitude of bleeding disorder on women. What are the challenges these women face in diagnosis management? How can we increase awareness to improve their diagnosis? The role of multidisciplinary management that was being mentioned in the guideline, so Dr. Magdi Al-Ikabi just talked about, and also briefly to touch on the managing abnormal uterine bleeding, which we know it's the commonest bleeding symptom. So going back to history, as you mentioned, Dr. Al-Alfi, that hemophilia is the most famous or known bleeding disorder in history, and especially in UK, it is an interesting disease for us because it affected the royal family in 19th and 20th century. And we know now that Queen Victoria was a carrier of hemophilia B, and she passed the trait or the mutation to various royal families in Europe, Russia, Germany, and Spain. And there are lots of books written about men in the royal family, about their bleeding disorder, how they suffered. However, there's very little written about the carriers, the princesses, which I have highlighted in red here, apart from blaming them for passing the mutation to different royal families in other European countries. Even in the literature, in the medical literature, women were seen as carrying the mutation and to men and making men suffer. As you can see in this publication in Lancet in 1886, it reads that it may be almost said that females hand down the disease and males are victim of it. But it was not until 1905 the nature of X-linked disorders understood, where the Y chromosome was discovered by Dr. Stevens, who was a scientist in US. And then it was realized that hemophilia, like any other X-linked disorder, that both men and women pass the mutation to the next generation. And we can even argue that women are fair. They give it to their daughters and sons, while men only give it to their daughters. But the story of von Willebrand disease, as also Dr. Ikabi mentioned, is a different story. It was described in 1926 by Dr. von Willebrand in Finland. He straight away described it as a disease different from hemophilia by the virtue of being more frequent in women. And Dr. Ikabi talked about his index case. The index case is this girl here called Hioris, who died of uncontrollable menstrual bleeding during her fourth menstruation. Two of her older sisters also died of GI and menstrual bleeding. And her great-grandmother here also died of postpartum hemorrhage. And he described the family as all the bleeder or majority of severe bleeders were women. But again, nothing much was done until 1956, 30 years older, where Dr. Inga Marie Nilsson from Malmo saved a life of another young girl who was going to die from menstrual bleeding by using this product that she's holding, and she called it anti-hemophilic globulin, which we know now it was some kind of plasma product, and she described it as a preparation to give some time until we remove the source of bleeding, which obviously was the uterus in that young girl. And these are the graphs of the bleeding time, coagulation time after giving this product. The bleeding calmed down. The young girl had a hysterectomy, and she actually lived for a long life after that. Again, women issues were sort of ignored until in 1990s when there was initiatives from UK and other European and US and even in Egypt to increase awareness about women's issues. And I'm really actually privileged to have been able to be part of the team working with Professor Lee. All of you know, we started the joint clinic, the concept of multidisciplinary and comprehensive care for women and girls, and we started clinical research that led to improve awareness of women issues in UK and abroad. So really, what are the impact of bleeding disorder in women? Well, we know that women with bleeding disorder, like men, they suffer the general bleeding symptoms, epistaxis, bruising, bleeding after surgery. And this is a small study, a case control study of 114 women, severe bleeding symptoms, i.e. bleeding score more than 12, was present in almost half of the women who had a bleeding disorder, compared to 0 for women who do not have any bleeding disorders. On top of that, these women have the challenges every month of having menstruation, ovulation. Obviously, there is a challenge of pregnancy, miscarriages, and childbirth, and that leads to the variety of obstetric and gynecological bleeding that I have highlighted here, and that spans during their reproductive life. But we all agree that the commonest bleeding symptom for women is heavy menstrual bleeding. And here I will show you data from our center and from Milan, so showing that majority of women with bleeding disorder, even if it's a mild von Willebrand disease or carrier of hemophilia, they have heavy menstrual bleeding. In von Willebrand, 70%. In some rare bleeding disorder like Glanzmann, they have really severe heavy menstruation in over 90% of them. And because it's every month, and there is also possibility of ovulation bleeding, other gynecological bleeding, there is an important or a negative impact on their health. So they are more likely to be anemic throughout their reproductive life. They may end up not having hysterectomy at early age because of the severity of bleeding. They may not respond to one or some of the medical treatment. And also quality of life is impaired, as seen in these published studies, not only quality of life, but it impacts on their schooling, academic achievement, their work and career progression. In pregnancy, we know that some bleeding disorders, especially severe fibrinogen deficiency, factor 13 deficiency, and also factor 10 deficiency, may be associated with pregnancy loss and antepartum hemorrhage. But all bleeding disorders, even the mild ones, have high risk of postpartum hemorrhage, as you can see here, and this includes primary and secondary postpartum hemorrhage. So this is a survey that was done by European Hemophilia Consortium a couple of years ago, and more than 700 women with bleeding disorder responded from 32 European countries, and it clearly shows a significant impact on all aspects of life: physical, romantic, active life, also reproductive life, because 1 in 4 women reported that having a bleeding disorder influence severely their decision making when they want to start a family, or even when they're thinking to have a child. And also the survey highlighted that the symptom that most has the most impact on their life is the heavy menstruation, and that is clear because it's every month. And these are some of the dramatic way they described how it affected them. Unfortunately, I don't have time to read through all these comments. So what are the challenges in diagnosis and management? Is that all right? You can hear me? All right. So the challenges for women and to get diagnosed and managed is that despite the fact that heavy menstruation is very common among these women and girls, but it is seen in the family as normal because all their mothers, sisters, and cousins have bleeding disorder because of the inherited nature. So this leads to delay in asking for help and getting the treatment that is important to prevent long-term consequences and improve their life. And delay in diagnosis is well documented in all the studies. And again, this is the same survey that I mentioned to you a couple of minutes ago. And the survey clearly showed that even in Europe, there is a delay in diagnosis for women, and average age at diagnosis was 16 years. But it was even longer, 19 years for carriers of hemophilia, and much longer for those who have some kind of platelet function disorders, and when there is no clear family history. And this is probably because there is a lack of access to care, disparity in access to care for women. They don't have access to hemophilia treatment center. And again, we did a survey through the European Hemophilia Consortium to ask the hemophilia treatment centers, how do you provide service for women in families with bleeding disorders? And you can see here, actually, more than half did not have service for women, and 1 in 4 of the centers did not have even a named gynecologist to liaise with and ask for advice when there is a gynecological bleeding. And there were lots of barriers reported, institutional, financial, to set up a service for women. So we really need to increase awareness and improve the diagnosis of bleeding disorder in women, and that only can be achieved by education. And education, not only healthcare professionals, but also women and girls and the whole family, the male relatives, and they should be educated before the age of menarche, the whole family, to know what is a normal menstruation, how much bleeding expected, when should they be worried and access or medical care and ask for help. These are simple charts that are available. We give to our patients and the families to help them decide and come for medical care early rather than leaving it late. For healthcare professional, education is very important, especially those who are involved in care of women, general practitioner, gynecologists, in addition to hematologists. And education should include understanding that obstetric and gynecological bleeding is very common for these women. Not only that, but also for the healthcare professional to understand that if a woman presents with heavy menstrual bleeding or ovulation bleeding, to think, is there an underlying bleeding disorder? And they should have the ability to diagnose and manage this kind of bleeding. Dr. Ikabi discussed how we diagnose, for example, von Willebrand disease, and of course we need a specialized laboratory to assess these factor levels, and this is not possible. We cannot just say every woman with a gynecological bleeding should have a full laboratory test. Therefore, we have to educate the practitioners, gynecologists, to take a good bleeding history, a good menstrual history, and also use simple tools, that is like this pictorial menstrual chart, and also bleeding assessment tool and score, to highlight those who really have a high bleeding score, high menstrual score, who are more likely to have a bleeding disorder and would benefit from referral to a hemophilia center or a hematologist for specialized testing. And there is no clear guidance who should be tested, but there is a consensus that these women should be tested for a bleeding disorder, for von Willebrand disease, and even other bleeding disorders when they have a heavy menstruation since menarche, or they have acute episode of bleeding needing blood transfusion, or if they are not responding to medical treatment before you do any hysterectomy or surgical intervention, if a woman has ovulation bleeding recurrently, or of course if the bleeding score is more than 5, or if they have a clear family history. And to get to that timely and proper diagnosis and provide a quality care, a multidisciplinary management approach, it is very essential for these women. And this multidisciplinary team should definitely include a dedicated obstetrician and gynecologist who has interest, who has experience in managing bleeding disorder in women, to deal with all the issues that, multiple issues that start from menarche to menopause. And the value of such multidisciplinary care is well documented. This is a survey that I wanted to share with you of our women who attend our joint clinic that we have been running for about 20 years. And the women, 90%, very satisfied with the service. They felt that they were provided an individualized care. They were involved in decision making and with minimal hospital visit, rather than going to the gynecologist and then going to hematologist. They just had one visit to have their problem sorted. Of course, when they are pregnant, we know that women with bleeding disorder, there is an increased risk of maternal and neonatal bleeding complication. And again, a multidisciplinary team is important, and that should include a midwifery team, obstetrician, anesthetist, neonatal team in collaboration with the Hemophilia Treatment Center and hematologist. And again, I would emphasize that having an interested obstetrician who always deal with bleeding disorders is very essential to provide continuous care from when the mother plans a pregnancy for a proper counseling to manage the pregnancy and delivery and also postpartum period to minimize the risk of bleeding. When we're managing pregnancy, our ultimate aim is to have a safe delivery for a mother and the baby, and that is the most important step in the management of pregnancy is a plan for appropriate plan for delivery, and that should be again done jointly by hematologist and obstetrician, assessing the bleeding risk, assessing the obstetrics risk, and have a thorough plan to decide what kind of anesthesia or analgesia should the women have, what is the best mode of delivery for mother and baby, what are the hemostatic cover or treatment that needed to prevent the bleeding complication for both. So for heavy menstrual bleeding, well, it is, as we know, it's the commonest bleeding symptom and it has a negative impact on them. Again, we need a joint care between gynecologist and the hematologist. And the input of the gynecologist is very important because we know that heavy menstrual bleeding or abnormal uterine bleeding is not a disease, it's a symptom, and it is caused by many possible causes. In these women, it could be due to their underlying bleeding disorder, but these women, like any other woman, they could have gynecological problem, a polyp, adenomyosis, fibroid. They could even have malignancy, especially as they get older. And that's why a gynecological assessment by a gynecologist with complete gynecological investigation as appropriate is very necessary. When it comes to treating heavy menstrual bleeding, we should really have a holistic approach to improve quality of life, not just the focus or reducing menstrual blood loss. And that's why we should consider the mother's, the woman's age, whether she wants to be pregnant, does she have any other gynecological symptom that should need to be looked into it? Is there any other pathology, polyp, fibroid? What are her acceptance of the side effect of whatever option you are offering her? What are her religious or cultural background that could influence her choice of the treatment? And I'm sure you all seen this algorithm of treatment that is commonly used for managing bleeding, heavy menstruation in women with bleeding disorder. We have quite a few choices: hemostatic, hormonal, surgical options. And our role as a multidisciplinary team, obstetrician and hematologist, gynecologist, should be to help these women to make an informed choice, to take the option that suits them best at that stage of their life. Just going through the effective treatments, I would say that levonorgestrone containing intrauterine system, which is called Mirena IUS, is been shown to be the most effective medical treatment for heavy menstruation in women with or without bleeding disorders. This is data from our center in women with various bleeding disorders. After a year of treatment, more than half did not have even a period, with improved hemoglobin and quality of life. But of course,
Razan, sorry, you have 1 minute only. I am
yeah,
very
sure. Not,
I'm
not
very
much. So these hormonal treatment have adverse effect, but they will resolve, and it's our role to have education and counseling to improve their acceptance. Other hormonal treatment important is contraceptive pill, and it can be given continuously without a break to minimize bleeding episodes. Tranexamic acid and DDAVP both effective, and factor replacement therapy in some severe cases, especially when the woman cannot take hormonal therapy and would like to become pregnant. Surgical management if they have a pathology, or especially when they completed their family. The simple one is ablating the lining of the womb when there is no big fibroids or any abnormality. We must also manage iron deficiency anemia in these women, because it is very common, and it's a simple treatment which definitely improves their quality of life. Very briefly, Dr. El-Ikabi touched on the guideline management. I was very privileged to be part of it, and I was very happy to see that 3 out of the 8 questions were in relation to women's issues. And then this is the recommendation in relation to heavy menstrual bleeding. What it highlighted is that we need more data. As you can see, the recommendation is a suggestion, is a conditional, but it highlighted important point that Dr. Ikabi said, the multidisciplinary management. And I would highlight one more thing, using multiple combination. So many women would need tranexamic acid, DGAVP, as well as hormonal therapy. So we should not give up just because one agent does not work. And very final slide, I would like to draw your attention to this initiative by EHAD that I was also I was involved, and happy about that we set up or developed the principles of care for women with bleeding disorders. And we just ran a webinar to discuss these principles of care. You can access it on this link. I think it's very interesting, and I would encourage you, when you have time, to listen to it. And thank you very much for listening.
Thank you so much, Dr. Razan, for this very, very informative presentation. And I think we will have the discussion at the end of this session, and it will be moderated by Professor Naveen Wali. Now I have the pleasure to introduce Dr. Sukesh Nair. Dr. Sukesh is an eminent person in the field of laboratory medicine in inherited bleeding disorders. He was the chair of the laboratory committee in the World Federation of Hemophilia, and he is part of the team in Vellore with Dr. Vellore, India, I mean. And he is now going to present us on the diagnosis part of the new guidelines. So Dr. Sukesh, thank you very much for attending us, and the floor is yours.
Thank you very much, Professor El-Kaibi. Is my slides visible?
Yeah.
Okay, fine. So first of all, I would like to thank Professor Magdi and Professor El-Alfi to have invited me to such a honorable forum. And my job was to do a critical appraisal of the new guidelines and probably existing guidelines for diagnosis of von Willebrand's disease, with especially focus on developing countries. We all know that von Willebrand's disease is the most common inherited bleeding disorder. It arises from the deficiencies and defects of von Willebrand's factor. And also we know that von Willebrand's factor has 2 primary functions or roles. One, it carries factor 8, and therefore it protects and stabilizes the factor 8 function. Without von Willebrand's factor, there's almost like a hemophilic scenario. Von Willebrand's factor has the most important function of allowing the platelets to adhere to the site of vascular injury. So just to illustrate these 2 functions, just imagine this is a blood vessel with all the coagulation factors flowing, and they are all in the inactive form like platelets. And then you have the von Willebrand's factor with the factor 8 that's being carried. So all these factors are in the flowing state. And just imagine if there is an injury, from the site of injury, all these coagulation factors will start flowing out. Now, something has to hold these coagulation factors at the site of injury. Otherwise, the flow of blood and flow of these coagulation factors from the site of injury keeps on going. Just imagine if the site of injury at the site of where there's an arterial bleeding, all these coagulation factors will be flying out, and nothing can hold this. The only thing that can possibly hold these coagulation factors, in addition to vasoconstriction, is this big protein. Of course, this is to highlight it that platelets will start flowing out with the flow of blood. Something has to hold the platelet at the site of bleeding, and that can be only done by this large protein, which is called von Willebrand's factor. A single moiety of von Willebrand's factor is almost 2050 amino acids. The picture that you can see on the screen on the top is actually the von Willebrand's factor moiety, single moiety, which is 2050 amino acids. And it has got places where the A1 part binds to the A1 part is the most active part of von Willebrand's factor, and that binds to the glycoprotein 1 platelets. So that's a platelet binding site. A3 part is the part which likes to bind to collagen, and collagen is usually hidden by subendothelial collagen. Only it will be exposed when there is bleeding. So now you can see that in blood, the von Willebrand's factor circulates not as just a single moiety, but 20 to 40 units put together, call themselves as multimers. And you must realize that multimers are folded inside the blood because they want to hide the active part, because if the active part is exposed, it will start binding to platelets in the circulation, causing a lot of problems, like it happens in conditions like TTP, where you can have platelet microthrombi formation. So the active part is hidden inside the roll, while the A3 part is exposed outside. And A3 part is the part which likes collagen. And we know that collagen is not normally exposed to von Willebrand's factor because it's usually hidden by the subendothelial, the endothelial cells. Now, once there is injury, the endothelial cells are disrupted and the collagen is exposed. And now the A3 part of individual von Willebrand's factor moiety will start binding to collagen one by one, allowing the von Willebrand's factor to roll out like a carpet, thereby exposing the active part of von Willebrand's factor, which has an affinity for platelets. So now let's look at what happens when the platelets are moving out, taken with the flow of blood. It finds something it likes, tries to bind to it, but every time it tries to bind to it, the flow of blood takes it off. But every binding will allow the platelet to develop resistance to the flow of blood, that finally it will have enough resistance to stop and bind to von Willebrand's factor, completing the process of platelet adhesion through glycoprotein 1b to A1 part of von Willebrand's factor. Just imagine if the von Willebrand's factor was not long enough, by the time the platelet is able to develop resistance, it gets taken away. This happens in a type of von Willebrand's disease where there is absence of multimer, and it's not an uncommon disease. It's a type 2A where there's absence of multimer, and the cause of bleeding is the simple physiology that I showed you. So now you can see that platelets are able to resist the flow of blood. They bind to the von Willebrand's factor, they get activated, release procoagulant peptides, which attracts more platelets. They also get activated and mediates the process of platelet aggregation, which is glycoprotein 2b3a, fibrinogen or von Willebrand's factor, allowing the formation of platelet plug formation, which is the primary hemostatic plug. So this is what is essentially done by the role of platelets and von Willebrand's factor. And now you can realize how important von Willebrand's factor is in allowing the primary hemostatic plug. So the classification, as Professor Magdi showed you, it's a quantitative deficiency, either type 1, which is a mild deficiency, or type 3, which is a virtual absence of von Willebrand's factor. Or you can have the qualitative defects, where you have the absence of multimers that I showed you in the example earlier. It's a type 2A. Or you can have abnormal multimers, where the platelet don't have the ability to bind to glycoprotein 1b. And I mean, the von Willebrand's factor doesn't have the ability because that particular part is defective. That's called type 2M. M meaning the multimers are present, but they're abnormal. Then you have the type 2B, where there is an increase binding of platelets to von Willebrand's factor. And because of that, it will form small platelet aggregates, reversible platelet aggregates in circulation, which gets cleared, by which the von Willebrand's factor multimers are removed, or high molecular multimers are removed, leaving the blood with only the low molecular multimers. And then finally, you have the rare condition called type 2N Normandy, where the von Willebrand's factor does not have the ability to bind to factor VIII. So the diagnosis of von Willebrand's disease requires these few criteria. One is trying to examine for the cause of, the site of bleeding, then the history of bleeding, a family history of bleeding, because it's an autosomal, majority of them are autosomal dominant. So there will be a strong family history, as Professor Kadir showed the family history in the Eric von Willebrand's family. Then, of course, age, gender, and recent drug history is very important. Pregnancy, because it affects the von Willebrand's factor level, or estrogen therapy, menstrual cycle stage is also important because that can affect the level of von Willebrand's factor. And finally, we know that in the ABO blood group, O group people generally have low von Willebrand's factor than other AB groups. Now, for working up, you have three types of tests. One has the screening test, which will try to tell you that possibly this patient with bleeding may have von Willebrand's disease. Then you have to do the specific test, which will tell you that there is a possibility of von Willebrand's disease, in which you need to do the factor VIII assay, then the specific quantitative assay for von Willebrand's antigen. Then there is a functional assay of von Willebrand's factor activity, which is a platelet dependent activity of von Willebrand's factor. Commonly, it was a ristocetin cofactor assay. Then, of course, there's another activity assay called collagen binding assay, but the standard is the ristocetin cofactor assay, which is the platelet dependent von Willebrand's factor activity. Now, once you identify that there's von Willebrand's factor, and then you know that there could be a possibility of a qualitative defect rather than a quantitative defect. For a qualitative defect, because there are 4 subtypes, you need to do discriminate tests to identify each subtype. For example, low dose ristocetin induced platelet aggregation to identify type 2B, multiple analysis to classify type 2A, and factor VIII binding assay to show that type 2N does not have the ability to bind to factor VIII. Now, coming to the specific test details, factor VIII assay is commonly done by the one-stage APDT-based assay. There are chromogenic assays available. They are widely available on automated instruments. In CMC, we do it on Coag Expert by Stego. Von Willebrand's antigen can traditionally done by ELISA. Then, of course, you have the lattice immunoassay, also a immunoassay system, all clear. Also widely available on automated instruments. In CMC, we do the AccuStar CLIA for von Willebrand's antigen. Now, coming to the platelet-dependent von Willebrand's factor activity, the RECOF activity, initially it was done by aggregation of fixed platelets in the presence of ristocetin. What ristocetin does, it basically opens out the von Willebrand's factor, exposing the A1 part, which binds to the platelet glycoprotein 1b, and thereby looking at the aggregation of platelets. Of course, it has been further refined by looking at specific identification of A1 part of von Willebrand's factor to see whether that is intact by an antibody against the A1 part. Then newer assays have come up, which looks at just the glycoprotein 1b entity of platelets to bind to the von Willebrand's factor in the presence of ristocetin, or using a mutant type 2b mutant whereby, the glycoprotein type, the platelet type mutant, whereby you can see that you can get the von Willebrand's factor to bind to glycoprotein 1b without the presence of ristocetin. Now, all these are available on automated instruments. Now you have the fully automated RECOF available on CS series. Then you have the antibody based assay on A1 available on the IL instruments, and of course the glycoprotein available on Siemens. In CMC, we do the AccuStar glycoprotein 1b based on ristocetin assay. Collagen binding assay, you can either do in-house ELISA. There are commercial ELISAs available, and there are fully automated systems available on AccuStar. And in CMC, we use AccuStar CLIA for collagen binding assay. Factor VIII binding assay is also an ELISA base, but finally, to detect the binding factor VIII, you can either use an antibody to factor VIII and look at the color that produced, or you can do a chromogenic assay. In CMC, we do the ELISA using the antibody that produces color. Multimers, of course, are in-house assays. You can either do the staining on the plate itself, or you can do blotting. Nowadays, there is an automated system available by CBIA. Of course, multimers are very rarely done in CMC, probably once in 3 years, when we really want to identify a particular subtype which cannot be identified by any of the 4 assays. So in the algorithm in our lab, we have basically taking the history of the patient. Once it's significant, we do the screening tests, APTT, we do a bleeding time, we do PFA 200, and we also do the blood group. Immediately after that, we also do the ristocytin cofactor assay because that is slightly cheap in our hospital. So we do that. Then we do the factor assay and also a low dose REPA. If the recough is low, we proceed to do the antigen. If the recough is normal, we don't do the antigen. Now, with these results available, by afternoon, we are able to provide the patient a diagnosis of either type 1, type 3, or type 2B because of the low dose REPA. However, if the antigen, the recough, the activity assay is lesser than the antigen of less than a ratio of points, less than 0.7, we can also provide the diagnosis by afternoon to the patient, whether the patient has got either a type 2A or type 2M, type 2M being more rare. However, because we know that von Willebrand's disease is an inherited bleeding disorder, and these children, if they come present as children, we try to catch out the parents who come with the children and also do of the bleeding time, PFA, factor rate, and recough and antigen on the parents, because we know that one of them will carry if they are having an autosomal dominant disorder. They may not be symptomatic though, along with the blood group. So this allows us a little bit more confidence to give a diagnosis of an inherited bleeding disorder. Of course, the rest of the samples are frozen for factor rate binding assay in case there is a suspicion of nominee. We have not identified a nominee till now, other than the samples that come from an external quality assessment program. We freeze the sample for collagen binding assay, which is very frequently done, and multimer analysis. So once these assays are done, if the factor rate binding is less than 0.7 to an antigen, we can give a diagnosis of type 2N, which we have never given to a patient till now. Of course, the collagen binding assay is very useful because if it is lower than the antigen at a ratio of less than 0.7, and if the recough is fairly normal, we can confidently say that the patient has got type 2A. And if the recough was very low, we can possibly suggest type 2M, but cannot rule a type 2A. But if the recough is normal, we can confidently say the patient has got a type 2A.
Dr. Sukesh, we have like
Now,
1 minute.
Okay, fine. Sorry. So, just to show that the problems in the developing countries, you can see that these are the data from IQOS, where it shows that how many participants we have from developing countries, 115. And these are the only 86 of them are able to return results, which are having part of the von Willebrand's assay. And you can realize that when they are returning results of APTT, only 71 are able to return results, of which 44 are not able to return results because they don't have antigens, the reagents available. As far as von Willebrand's assays are concerned, you can see that these are the spread of the assays that are available from various parts. You must be very fortunate that you belong to North Africa, where 5 participants are there and all 5 produce a good amount of results to von Willebrand's assays. But you must realize that among those people who provide all these specific assays for von Willebrand's factor, 18 of them are frequent outliers. So, the recent guidelines which talk about most of the assays, these are not available in BAT, of course, is a new assay which Professor Kadir talked about. But there is an issue with BAT because they were talking about BAT being a good tool to harmonize history.
Mayor, we have to go for the conclusion, please. Thank you very much.
Okay, fine. So I want to say that clinical practice is not harmonized in these countries. For example, unnecessary transfusion, antifibrinolytics. And of course, these assays are not widely available in the world. And so we were trying to talk about why don't these guidelines talk about screening tests? And one of the tests being simple tests like skin bleeding time, which can be done by simple devices. Though there is no standard for it, you can at least tell that by the look at the bleeding at the end of 1 minute, how you can say that the bleeding time was done properly. Though we know that it's a difficult test, but looking at the end of 1 minute, the way the bleeding happens, we can say that the bleeding time was done properly. Otherwise, we know that this bleeding time was not good. So I was just trying to show that the results of skin bleeding time, how useful it is to pick up patients with severe types of von Willebrand's disease, and skin bleeding
please,
time.
Please, we go for the last slide, please, Professor Nair. We go to the last slide, please.
Yeah, so this is basically to show that skin bleeding time is done properly.
You go, please, for the last slide. Excuse me.
Last slide is basically hemostasis is like love. Everyone talks about it, but nobody understands it.
Yeah, sorry for the limitation of time, Dr. Sukesh, but because the program is very
great building, a nice building.
Yeah.
There should be a lot of work inside.
Yeah.
Thank you very much.
Thank you, Professor Nair, for this illustrative presentation about diagnosis of von Willebrand guidelines. Thank you. I'm honored now to present my colleague and friend, the Professor Khadija Tombari, one of the eminent, dedicated, meticulous, updated scientists in the field of pediatrics in general and the hematology oncology specifically. She will present to us 10-year experience of low-dose SD cryo in prophylaxis. Go ahead, Professor Khadija.
Thank you so much, Professor Naveen, and I would like to extend my thanks to Professor Alfi for giving me this chance, and Professor Magdi Al-Ikyabi for allowing me to share his work with cryoprecipitate. Okay, so to make it short for time, so as Professor Qadir said, that maybe hemophilia is a royal disease, but actually it was first reported by Abul Qasim al-Zawahri, who was our Arabic scientist, and it was reported around 1936 Common Era, and it is estimated that 1 per 5,000 male births is going to suffer hemophilia A. So let's talk about our topic today, which is cryoprecipitate. The history of cryoprecipitate started in 1964, where Jude Spool discovered that the cryoprecipitate fraction of plasma contained proportionally greater quantities of factor VIII, and then going to 70s and 80s, there was large numbers of people with hemophilia becoming infected with blood-borne viruses. In 1982, it was the first report of a US patient infected with HIV virus. And during the mid-1980s, this was the first report of the genetic sequence of factor VIII gene, and the recombinant factor VIII was first infused in 1987. Through these years, viral safety was a question, but since 2000, the main concern of hemophilia caregivers was not only the safety, but also the future cost and the effectiveness of long-term treatment. So we need a clotting factor concentrate that is always safe, and we should know that the prophylactic replacement of clotting factor has been recommended as the gold standard of care by the World Federation of Hemophilia and the World Health Organization. We saw this slide yesterday with Professor Tantawi, which is the levels of care of hemophilia patients. Either we go from up to down, where we can give on-demand treatment with bleeding, or with tertiary prophylaxis after the onset of joint disease, or then secondary prophylaxis after second joint bleed, or to start early on before the age of 3 with primary prophylaxis before the second joint bleed, and give the patient the chance for near normal musculoskeletal and psychosocial development. So what's the current situation? Most of the developed countries guarantee to their population the availability of such effective products, but in developing countries with low human development index, and according to the World Federation of Hemophilia, the situation of patients with bleeding disorders is unsatisfactory, that about 75% of patients have no access to proper or appropriate forms of treatment. So what's the trouble with the clotting factor concentrates? Virally safe clotting factor concentrates not only increase the economic burden, but also there is a chance of inhibitors. And as you all know, the famous CIPET trial, which included about 70 patients from centers in Egypt, it studied two types of factors, the plasma-derived factor VIII and the recombinant factor VIII. And to summarize, the cumulative incidence of all inhibitors was more in recombinant factor VIII with 44.5%, while the high titer inhibitors were still more with the recombinant factor VIII, about 28.4% versus 18.6% for plasma-derived factor VIII. And most of the inhibitor development happened during the first 50 exposure days. So an ideal product should fulfill these three issues: to be safe, affordable, and least immunogenic, with the possibility not for not developing inhibitors. So cost and effectiveness of cryoprecipitate, as you all know, cryoprecipitate is a component containing mainly factor 8 von Willebrand factor, fibrinogen, and factor 13. And viral inactivation is now available in most of the countries, and it's reported by John Faber that in Egypt about 1/3 of the national factor consumption is covered by viral inactivated cryo. So viral inactivation can be through different methods, either the solvent and detergent viral inactivation, as well as bacterial filtration of many pools, which we are going to talk about, viral inactivation by amoxicillin, or viral inactivation by riboflavin. This is an illustration of the bag of cryoprecipitate, and it describes the amount of factor 8 fibrinogen and von Willebrand factor. 20 to 30 ml gives a dose of 250 international units of factor 8, and it's doubled with 40 and 60 ml of cryoprecipitate. El-Iqabi and his group studied earlier in 2011 or 2010 the pharmacokinetics of solvent detergent filtered cryoprecipitate in 11 severe hemophilia A patients, and with a mean age of 17 years and a mean weight of 58 kilograms at a dose close to 40 international units per kg with after 1 week washout period. And they found that the mean recovery of factor 8 at 10 minutes post-infusion was about 70%, and that solvent detergent filtered cryoprecipitate factor 8 had a half-life of 14.2 hours. Patients reported remarkable sense of improved activity and disappearance of pain due to chronic arthropathy, and all patients had a bleeding-free interval of about 8 to 10 days. Another study looking at tailored prophylaxis in severe hemophilia A using the same product, which is SDF cryoprecipitate. 12 severe hemophilia A patients with a mean age of 9 years and a mean weight of 30 kilograms for duration of about 5 years had a tailored dosing where 8 kids were on 1 weekly, 3 kids were on twice weekly, and 2 kids were on thrice weekly doses. The mean dose was 15 international units per kg, and mean annual dose was almost 1,000 international units per kg. And to comment on this study, the bleeding data showed that the mean number of joint bleeds per year is 2.64. Mean number of muscle bleeds was 1.1, and one patient only developed target knee joint, which was treated by arthroscopic knee radiofrequency, and another patient developed a target ankle joint, and it was managed by intra-articular injection. There was no report of serious bleedings and no reports of any viral positive screens or any inhibitors. And this is the hemophilia joint health score. And during the study, it ranged from 0 to 5. And as you all know, it's a score of 20 for each joint, so 120, and 4 for the global gate. So it's a score of 124. So the range was 0 to 5 on the study. All boys were punctual at school, and some of the kids participate in regular schools, regular sport activities as swimming. So with 6 to 10 years of experience on tailored prophylaxis using the ST filtered cryo, it shows efficacy compared to standard prophylaxis program, viral and immunological safety, and what's very important to developed countries is sustainability through local supply with significant cost saving. Thank you so much. I try to be punctual and stay safe. Thank you so much.
Thank you, dear Professor Khadija, for such illustrative, simple presentation about the role of cryo-SD here to be adjunct to our concentrate in treatment of severe hemophilia A patient. Thank you, Professor Iqabi, for giving us such cryo-SD. Thank you.
I would like to thank this wonderful session. I would like to thank Razan and say sorry that maybe she couldn't finish her the whole presentation and have chance to enjoy the question and answer session. Professor Khalid Al-Hudaybi could chair the session, Professor Magda Racha, and Magdi, Khadija, Rasha, all chair and speakers are more than welcome. Now for 15 minutes, we will hear from the Iron Woman, what is the story of Iron Woman and how we could support our hemophilia population before we go to Takeda Symposium. Razan, thank you very much. And I hope if you have time to continue with us, it will be an honor. And we will have Gary Dolan after that speaking after the Iron Woman. And Amani, Khadija will share your presentation and whatever you'd like to say. And you should be full screen, Khadija, if you can. Go ahead, Amani.
I can start my my talk now.
Yes, please.
All right. First of all, my name is Amani Khalil. I am an Egyptian mother to two young gentlemen who are working now, and a wife to a professor in accounting. And really, I am so delighted and honored to be sharing my story here with all of you. Before I start, I would say I could start off with if 30 years ago someone would have told me that you will swim 4 kilometers in open water and cycle for 180 kilometers, and then right after that finish a 42 kilometer run, a full marathon, I would have said, you're crazy. It's impossible. No way. Well, the impossible became possible, and I will share my story with you and show you every step I took to reach that dream. I started off, I graduated from with a business degree from AUC, and I went straight into a banking career following my mother's footsteps. I stayed there for 3 years until my husband decided he wanted to move abroad and continue his PhD degree. I said to myself, you know, why not? I'll resign from the bank and help him, support him. And at the same time, I was a bit ambitious to continue my studies while he's there. What happened was we traveled, and it didn't work the way I wanted it because we got both of our 2 boys, one after the other. And so I decided I will stay home and raise them. As you know, there's no support in America. We were in Pennsylvania. And so I decided to stay home for the kids. Something was missing in me, and I didn't know what it was until one day I woke up early in the morning and I found people running in the streets. Now, where I come from, Cairo, Egypt, we do not do sports in the streets. We have clubs, we train in clubs. And so to me, this was different. And I found them, they looked so healthy, happy, and safe. And I said to myself, why not? Let's give it a try and join them. I did, and they welcomed me, and I ran with them every day. And I used to go back home feeling energetic, feeling healthy and happy that I could continue the rest of my day taking care of my kids in my home. I continued running and I got better, and someone noticed that my pace was improving. And so they asked me, why don't you join a 5K community race? And I said, okay, why not? I joined the race. I came in 5th place. And I fell in love with running in the streets and racing. So 5K led to 10K, led to 15K, 21K. And by the time my husband received his PhD degree, I was able to finish my full marathon in Dallas, Texas. So we returned back to Egypt. I'm very happy with my medal. My husband is happy with his PhD degree, and I have our 2 toddlers. So the runner in me wanted to continue in Egypt, but running in Egypt is not the same as running in Dallas, Texas, or Denton, Texas, where I lived. So I was scared because there were dogs running in the streets after me. The cars never gave me the way. Yes, I received a lot of sexual harassment. It was just not easy, but It's something I loved. I found that I'm not doing anything wrong by continuing to do something I love. So I decided to continue. I ran around the block first and then ran around the island because I live on an island in Cairo, in Zamalek, Egypt, Cairo, Egypt. And I was really happy that during my kids, when they were in school for the 12 years, I finished 16 international marathons. I used to travel every year abroad to do an international marathon and come back. So this went well. I continued my running. When they got into college, I found more free time. So what do I do? What do I do? Again, by pure coincidence, this young girl comes to me and she says, I really want to run a marathon like you. Could you help me? And I said, what is your background? What do you do? She said, I do something called a triathlon. And that's 3 sports in one, but very small distances. And I got curious and I said, all right, I will teach you how to run marathons, but will you teach me how to cycle and how to swim? So I went and bought a bike at the age of 47. I never knew how to ride bikes before, except when I was a little toddler and it was a tricycle. So I received a lot of comments again from some of my friends and people that saw me in the street, you know, how could a woman your age run cycle in Cairo like this? And I was like, you know, why? What's wrong with a woman becoming a triathlete? What's wrong with a woman riding a bike in the streets of Cairo? And I continued, thank God. And I practiced with her team, which were all about the age of my kids, but they really welcomed me and they were so happy to see a mother like me wanting to learn and willing to finish a triathlon. So I continued with them and I did my first race in 2014, and I was 47 at that time, years old, a duathlon, because I was still very weak in swimming. I did the duathlon, which is only cycling and running. And again, I came in 5th place and they were so happy with me. They said, you know what? We will train you again. And maybe at the end of the year, we're going to do something, a triathlon in Sahl Hashish. This was the first triathlon to take place in Sahl Hashish. And I did the Olympic distance, which is about 1.5 kilometers of swimming and 40 kilometers of cycling and 10 kilometers of running. And I, again, did very, very well, and I finished it. And these young kids came to me and they said to me, you know what? We're thinking of doing something called the Half Ironman. And I said, really, I would love to join. And will you take me with you? They said, yes, but you need to practice very hard and in Cairo. So we practiced together, and they used to take me to Sheikh Zayed to practice because there was a little Arkan hill there. And I had to go on that to train because I knew that Barcelona, where we were going to go do the Half Ironman, was very hilly. So I went and practiced with them. And in the year 2015, we traveled to Spain. Again, a lot of people commented, especially some of my friends and my extended family, on being against me traveling with these youngsters because it was their dream, not my dream. And they said, how, you know, could you leave your kids and your husband to go and do a race like this? It's crazy. And you're not going to succeed. It's not your age. It's all this negativity. But again, I said, why not? There's nothing wrong with this, and I trained well, and I'm ready for it. Well, the shock of my life was when I traveled with these young kids to find in the first day of the race. It's only 1-day race. The conditions there are quite different from Cairo, Egypt. First of all, the water was freezing cold, very cold water, freezing water. It was very rough. There were waves. I'm not used to this. And thousands of people beside me that are going to go into the water at the same time. And I'm not used to this. I was used to swimming or in a bay. And so this was a little bit different for me, but I passed the swimming. And then came the biggest shock of my life, and that was the mountain. The mountain was very scary for me because it was a mountain that you have to go for 45 kilometers up with and it was twirling. It was going around the mountain to reach up to the top, 600 square meters above sea level. And I never, you know, in Cairo, we usually train on flat streets. We don't have mountains. So it was not easy. I did go up and I finally went down, but I did not make it within the cutoff time. I came in 12:36, and I was supposed to go in 12:35. So I came in 1 minute late. The official took the chip away from my leg so I could not continue the race and go for the run, and I was disqualified. I was so sad, and I returned back to Cairo, everybody telling me, we told you so. You went and followed the wrong dream that doesn't belong to you, and you are old, you are not fit for such an endurance sport. And this made me more than determined, especially when my 2 kids and my husband were supporting me and continued supporting me. They gave me the chance to try it again when they said, okay, we know you want to go for this again. And I did go for it. And I decided I will train more and will find people with good expertise, help that can help me climb a mountain and that can help me swim in open water that's rough. So I did find the right people. GBI taught me how to go to Sinai and climb the Saada mountain, which is 800 square meters above sea level. And when I did this race with them and succeeded, it gave me so much confidence that I will be able to do Barcelona again. Also, I went to the Ain al-Sukhna and I was training with this team of swimmers that taught me how to swim in the open water with lots of people around me. And I succeeded and I was able to finish it. And came 2016, May, I went for the same race, the one that I failed on the first trial. And lucky enough, or not lucky, I was really actually very fit and ready for it. I was able to succeed in finishing it within very good time. And the climb of the mountain, I finished it 33 minutes earlier than the minute that I came in late. I finished the half Ironman, came back, lots of people, of course, congratulating me. And what happened was June 26th was my 50th birthday. And between me and myself, I said, the best gift I could give to myself as a 50-year-old woman is to apply for the full Ironman in the same year. I said, all I have to do, I asked my coach, Khadija Amin, who was the first Egyptian Iron woman to finish an Ironman. She finished it when she was 28 years old. And she said, I will help you. I will give you all my experience and I will help you do the Ironman and train you for the Ironman. So I trained 7 hours a day. I would wake up early in the morning at 5 o'clock to go to the swimming pool and swim for 2 to 3 hours before people start to go and use the swimming pool, especially the teens. Then I would go home, have my breakfast, return back again to the club to train in the gym for about 2 hours of strength training. Then I would go back home again, feed my kids, feed my family, my husband, and get a little bit of power sleep before I start training again at night. And that was either running or training on my bicycle on a trainer. 7 hours a day for almost another 5 months until October 2nd, I decided to take my family with me this time. I wanted them to see what I was training for all this summer and to come see me finish a full Ironman. So we traveled to Spain. My husband left his job for me to come and see and support me. My 2 kids left their university to come and support me. And they were all there for me to watch me finish the full Ironman. What happened was I got into the swimming, the sea. It was the Mediterranean, Barcelona. And I finished the 4-kilometer swim in 1 hour and 27 minutes. And then I got into the cycling and finished the 180-kilometer cycling in 6 hours and 11 minutes. And then I get into running, which was my favorite part, but it was a full marathon. And I find the biggest surprise in my life, and that where my 2 kids decided to run beside me, each one running 5 kilometers by my side so that they keep me company and help support and push me as I was running. And that was such a lovely surprise from them because I was not expecting it. So they had to be outside the yellow line so that I don't get disqualified. And they ran with me 5 kilometers each by my side until I reached kilometer 30. When I reached kilometer 30, something went wrong with my body. It totally shut down. I could not continue. I was very dizzy, very nauseated. My legs felt like steel, tons of steel. And I was so afraid to fall down, because if I fell down or took some rest and sat down, I was worried that I might not be able to walk up again and continue the race. So what happened? My kids started shouting at me and screaming at me, telling me, "Mom, you are making history for Egypt. You finishing the race will allow many women your age to run in the streets, to continue doing sports, to compete even." So this gave me a second wind, and I was so happy that they talked me into this. And really, they did push me by starting to sing to me songs so that I would not concentrate on my body and focus my mind on their songs. And sure enough, 500 meters away from the finish line, I find my son taking out his phone and calling his father and telling him, "Dad, she's almost there. She's almost reaching the finish line." And so I did find my husband waiting for me near the finish line. And my husband, who does not like running at all, he came and ran with me the last 200 meters until he got me to the red carpet. And once I touched the red carpet, he pushed my back and he said, "Amani, your dream came true and you really made it. You're there. You are an Iron Man." And lucky enough, I found the red carpet and I ran, taking my Egyptian flag out to show everybody that an Egyptian woman can do an Iron Man.
Amani, you are an honor for every Egyptian woman and every Egyptian man. Thank you very much for being with us for this nice 15 minutes. Give us the spirit and the appreciation that women can do a lot and Egyptians can do this, which is not used to be an Iron Woman. And now we close the session of guest speaker Amani Khalil, and we go for Takeda Symposium. And we are honored to have two excellent speakers, Professor Gary Doran from London and Professor Mona Amraoui from Cairo University. Professor Gary Doran, please share your presentation. He is a consultant hematologist, and he is the director of hemostasis thrombosis in St. Thomas Hospital, and he is also the past president of the British hemostasis thrombosis. Meanwhile, he is still for 10 years the chairman of the European Hemophilia Therapy Standardization, and we are honored that Gary at last could make it and come to Cairo through webinar. Maybe next year we become face-to-face, and he will address his important topic on factor hemophilia inhibitors with a special focus on ITI. Gary, if you can, if we can stop sharing FIBA. FIBA is now approved in Egypt, and we go for Gary to share his presentation.
Thank you very much. If you just hold on a second. So, Salam alaikum. Thank you very much for the invitation to speak to you. It's a shame that I can't speak to you in person, but hopefully this year we'll get to meet each other again, inshallah. So I've been asked to talk about the role of ITI in the management of hemophilia A with inhibitors. These are my disclosures. So as we all know, if you give a patient a protein that they don't possess, then they may develop antibodies. And it's the same with hemophilia A. If you inject factor VIII, then a proportion of patients will develop neutralizing antibodies or inhibitors. And we know that this rate of inhibitors has been pretty constant from most of the studies which have looked at this over a long period of time, but around about 20 to 25% of patients will have high responding factor VIII inhibitors. And these are data from the UK showing that almost all of these patients are children. So this is the main focus of our pediatric colleagues. And there's possibly a later peak in a much older group of patients with haemophilia. So the big issue is immune tolerance induction. Why should we try that? And it's because we know that children and adults who have long-standing inhibitors have higher morbidity, mortality, lower quality of life. They can have terrible arthropathy, and they miss out the normal childhood. And not only that, but if you depend completely on bypass therapy, it may turn out to be more expensive in the long run than ITI. These are estimates in the US and looking at fiber costs or over a period of time and Novo 7. So if you achieve factor VIII tolerance after developing antibodies, then it allows effective prophylaxis. It allows the patients to be treated more easily for surgery. You can manage breakthrough bleeds more easily. It opens up more options for future treatment, such as gene therapy. And there is an increasing interest in the maintenance of factor VIII in other conditions, such as bone health. And I think the data are still premature on that, but I'm sure there'll be interesting data emerging over the next few years. So the first important thing is that really, if you're embarking on ITI, then it has to be through centers that have experience with this to minimize morbidity and to ensure you have the responsive laboratory and other support services and optimize the chances of ITI. So how do we prepare for managing inhibitors? The first thing is to make sure you screen for inhibitors so that you pick up the inhibitor early before it can cause a lot of damage and before it can cause life-threatening bleeding. This facilitates the early start of ITI, which is becoming the preferred way of treating people. The next question is who should have ITI? And it's clear that it's recommended for all patients with severe hemophilia A and a persistent inhibitor. And even low-level inhibitors can be formally or should be formally tolerized. And they can be tolerized using more straightforward regimes, factor VIII concentrate. And our important question really is what dose to use, because there are a lot of different regimes have been used over many decades. We have the low dose regime, the intermediate dose, and then the high dose. And all of these have been published and they all show success. So all of them can show success, but until relatively recently, it's never been tried in in a trial situation, head to head. I mean, the different studies have all shown slightly different results because of different definitions, different aims of the trial and different inclusion criteria. But what is clear is that you have to continue until patients restore normal PK. That means that they can either have a recovery of 66% or a measurable trough level after 50 units per kilogram. And obviously a failure of tolerance is failure to tolerize and achieve these responses. Interestingly, these are data from the UK showing factor use in children and adults and whether they've had a history of inhibitors. And it's interesting to note that children and adults who've had a previous inhibitor tend to use higher levels of factor ongoing. And it raises the possibility that maybe not all patients are fully tolerized, but they tolerize enough to be able to be treated with factor VIII. So the ITI study, which was led by my good friends Charlie Hay and Donna Di Michele, looked at this comparison between high dose ITI and low dose. And the interesting and probably the most important message that comes across is that both of them will tolerize. So you can achieve the same level of tolerance with both regimes. It will just take longer with the low dose regime. And this is a summary of that, showing the length of time it will take to tolerize in the low dose regime compared to the high dose regime. Now, importantly, the issue that has, apart from the fact that they're equally effective, is that you get more bleeds with the low dose regime and more hemarthroses. And so if you choose the low dose regime, then it may introduce some joint disease or may introduce some serious bleeding. But these can be managed by the use of bypass therapy, because use of bypass therapy, either fiber or Novo-7, does not impair the achievement of tolerance. And this is a graphical representation of the bleeds using the low dose arm and the high dose arm, showing both of them. The bleeds tend to happen in the earlier period and they tail off with time. Now, of course, this is hemophilia is expensive and ITI is expensive. I think there have been all sorts of studies which have shown it's more cost effective in the long run, but in the short term, you're still going to have to ask payers to fund this. And there is a big difference, huge difference actually, in the factor unit cost per patient comparing high dose to low dose. And even if you're using extra bypass therapy, the high dose therapy is still expensive. And so for that reason, a lot of countries choose the low dose option as being the most affordable one, and allowing more patients to be tolerized. So this is the summary. High dose is more factor VIII costs, will achieve tolerance quicker, lower bypass agent costs. Low dose, less factor VIII, it's slower and maybe higher bypass therapy. The high dose can be challenging though. It usually needs a central venous access device to achieve, in order to deliver the treatment. In the UK, we're very pragmatic, we're diplomats, and so we use a sort of halfway house. We use an intermediate dose, and we can either reduce that with earlier response or increase if we're not achieving response with an intermediate dose of 100 units per kilogram per day. The Americans have recommended a higher dose. That may change over time, but they usually start with, particularly for low risk, for high risk patients, 200 units per kilogram per day, and they can have a lower regime for good risk patients. So another thing is, well, when should you start? Because it used to be said that you had to wait until the inhibitor titer fell below 10 Bethesda units. And in fact, that was always one of the features of predictors of success, if you managed to get the inhibitor titer lower than 10 Bethesda units. And it's never really seemed that sensible to me, because the first thing that will happen when you start giving factor VIII is the inhibitor titer will rise. And there have been a lot of published results which have shown good success with starting ITI with titers above 10 Bethesda units. And in fact, it's common in some countries, particularly our German and Dutch colleagues, who've usually started as soon as possible. And that's exactly what the recommendations are now. There's no convincing evidence that if you wait for the inhibitor titer to fall, that the patients will respond better. In the meantime, they may bleed more. And I think in the UK, certainly people start as soon as the inhibitor titer is shown to be persistent. The inhibitor level is significant and it stays, it doesn't go away. So here's a couple of case studies from the UK. So this patient is 9 months old, originally from Eastern Europe, common intron 22 inversion, diagnosed at 15 months with an inhibitor titer at 31 at presentation. And he achieved tolerance pretty early in 4 months, but the inhibitor titer started falling at 3 months. So this was a good, excellent patient that responded very well and maintained tolerance. This patient, again from a similar background, diagnosed at 5 exposure days with an inhibitor of 22, and despite a long time of treatment, for 10 months, it was beginning to show some effect, but then it just started taking off again. And despite high dose therapy, the patient never really achieved remission. So which concentrate to use? Again, there's been lots of discussions on that, usually small studies, usually biased in some way. And the interesting thing from the international ITI study is that 90% of patients tolerized using the product they were using when the inhibitor developed. There was a move, in particular our colleagues in Germany, or some of our colleagues in Germany, who felt that a plasma-derived von Willebrand factor containing product would offer the best chance of success. And it was successful, but probably not much more successful than the other approaches. So there's no real conclusive evidence favoring any particular concentrate to use to achieve tolerance. A von Willebrand factor containing concentrate has potential biological plausibility, but our UK practice is that all of our children start on recombinant and they usually tolerize on recombinant. If they fail to achieve tolerance on recombinant, then we will often switch to a plasma-derived product to see if that works any better. What about resistant inhibitors? Because they do occur. I've mentioned the potential to switch to a plasma-derived concentrate. Immunosuppression. So a lot of people have thought about rituximab and they have used it. It destroys the antibody-producing cells for months. The downside is it can cause wider spread, immune suppression. But it may work, particularly in the short term, but very few in the long term. And this is a group of boys in London who have failed ITI with plasma-derived, and they've received rituximab. And you can see that the majority failed long-term tolerance, even despite an apparent response to rituximab initially, although some patients have achieved tolerance, and that might provide some encouragement. So immune tolerance induction, there's been a lot of debate now, particularly when you have new therapeutic agents which are available for treating factor VIII inhibitors. And I would say that ITI remains the recommended treatment for children with factor VIII inhibitors for the majority of physicians who look after children. Now, the one thing I didn't spend a lot of time is assessing the patients and their families, because there is little chance of success if the family cannot cope with the demands of ITI, either coming to hospital frequently for infusions or administering the treatment themselves through a central venous access device. And that may be in a big country like Egypt, you might have geography to play with as well. So is there a good chance of success of tolerizing a child who lives remote from the major centers who have more experience of ITI? And unless there's a good chance of committing to ITI by the family, the physicians, and the payers, then it may be potentially a waste of money. So, I think the selection process for patients is important. Thereafter, I think there is this interesting aspect of immunology that to maintain tolerance, you have to be exposed to the antigen. And so after ITI, you cannot interrupt the administration of factor VIII. You can't go from ITI to on-demand. The risk is the patient will relapse and you have effectively wasted the resource used to treat with ITI. And so I think patients should go from ITI to prophylaxis. It could be debatable how intensive that prophylaxis is, but they need regular infusions of factor VIII to continue. There's been a long discussion about the benefits of low dose and high dose. I think the international ITI study produced pretty clear evidence that both are effective. And actually, ultimately, they are equally effective. And that is an important determinant because, in the real world, the environment for haemophilia can be challenging from the point of view of cost. And some countries and some healthcare systems could only really look at the low-dose treatment as the affordable option, but it's still effective and still should be pursued. So the debate about the role of ITI is likely to continue for some time. The cost effectiveness versus other options will probably feature at many of the meetings you go to for some time to come. But certainly from the UK's point of view, ITI is still the standard of care for children with haemophilia A and inhibitors. So with that, I'd like to thank you for your attention, and I'd be happy to take any questions. Thank you.
Thank you, Professor Gary, for this concise, focused presentation. The question answer will be at the end of the session. And since activated prothrombin complex is now approved and registered in Egypt, Professor Mona El Ghamraoui, she is the GM of Abu Rish Hospital, Cairo University, and she has a lot of publications and a lot of contribution in clinical trials, and I think she was one of the co-PI in the CEPIT trial. Professor Mona will share her presentation on activated prothrombin complex, its role in the field of hemophilia. So we stop sharing the fiber slide, and Professor Mona El Ghamraoui is going to share her presentation. Then we will answer the questions. There are a lot of questions.
Good evening, everyone. Thank you, Dr. Mohsen, for your kind introduction, and it's really my honor to be with you tonight, and with Dr. Dolan. Hi. Actually, I know it's the end of the day, and you have been listening to lots of interesting talks. My presentation is about the activated prothrombin complex concentrate, or the APCC, in treatment of hemophilia. And now that you have already mentioned, Dr. Mohsen, that it has been approved in Egypt now, and it will be available soon in the market, hopefully. So we are going to talk about its use in the hemophilia treatment. This is my conflict of interest, and this is the outline of my presentation. So as Dr. Alfie has highlighted today, and again, Dr. Dolan, that having a patient with hemophilia with inhibitors represents a special challenge for all our team as hematologists, and hopefully it would not even turn to a nightmare, especially in low-income countries. So why is it a special challenge? Because those patients are at increased risk of uncontrollable bleeding. Their bleeding is difficult to be managed with conventional doses of factor replacement. They are usually at greater risk of musculoskeletal complications, especially joint damage, more chronic pain, more disease burden, worse quality of life. And of course, as Dr. Dolan has been saying, that they require individualized therapy in very expert and special hemophilia treatment center, and not to mention the controversy and the debate in the different therapeutic options available now for these patients. I'm not going to go again for the screening indications or inhibitors in these patients, but actually not for the hematologists. I only want to highlight these three indications, especially for our surgeons, general pediatricians and physicians, ENT consultants, obstetricians and gynecologists, as well as orthopedics. Please, preoperatively, after any intensive exposure or in failure of response to conventional treatment, we have to do screening for inhibitors. And how to manage? We have two objectives by our management. Number one is to treat and control the acute bleeding episode and to prevent or reduce the frequency of the recurrence of this bleeding. And the choice of therapy depends on several factors. One of them is the inhibitor titer, the site and the nature of the bleed, availability of the products, which is unfortunately one of the main factors controlling our decision, especially in Egypt and in low-income countries, and of course, the clinical response to therapy. According to the World Federation of Hemophilia guidelines, if we have low titer inhibitors below 5 Bethesda units, these patients can be managed by higher doses of factor VIII, and they might respond to higher doses. But if you have high titer or high responding inhibitors, then these patients should be treated by bypassing agents, whether it is recombinant active factor VII or by APCC or fiber. And to prevent further bleeding, there comes the option of the ITI to eradicate the inhibitors, which is unfortunately still very limited in countries like Egypt. or the prophylaxis either by using bypassing agents or now with the availability of non-factor replacement as the emicizumab. And here comes a lot of debate and controversy, just as Dr. Dolan highlighted that every patient with inhibitors should be considered to be put on to be tolerized. But now with the availability of other non-factor replacement, the quality of life, the venous access, so many other factors to consider, and a lot of debate and still very limited data about the emicizumab as well. And all this has to be taken into consideration in our decision making. So what is FIBA or APCC? Actually, this is a drug with a very long-standing history of more than 40 years, though in Egypt, it has not been available in the market for so many years, and hopefully it will be soon, inshallah. So what is FIBA? First, a background about its components and the mechanism of action. The FIBA is an anti-inhibitor coagulant complex, which is formed mostly of the zymogen form of factor 2 of the prothrombin, factor 9 and factor 10, and activated factor 7. But it also contains procoagulant enzymes, as well as cofactors as small amounts of factor 8 and factor 5. And also it contains naturally occurring inhibitors of coagulation in a physiologically balanced ratio as protein C, protein S, and tissue factor pathway inhibitors as well. So how does it act? How does it control bleeding? Primarily by inducing or facilitating the thrombin generation through the interaction with the endogenous clotting factors as well as platelets. The key player here, or the key component, is the prothrombin activated factor 10 complex. And this has a procoagulant activity both in vitro and in vivo, as we will see in the next slide how it acts. The proposed mechanism is through 3 steps. First, this prothrombin active factor 10 complex induces the thrombin generation through the membrane of what we call tissue factor bearing cells, as well on platelets, initiating the thrombin generation in small amounts, leading to an initial fibrin clot. This thrombin-mediated feedback results in, as you can see this dashed line, results in further activation of the clotting factors as well as activation of the platelets. In the meantime, the tissue factor pathway inhibitor slows down the coagulation activation through the tissue factor bearing cells, but at the same time, the zymogen forms and the procoagulant enzymes initiate or amplify the thrombin generation, what we call the thrombin burst, and result in a stable fibrin clot. And the long half-life of these zymogens allow a long-standing hemostasis, but as the circulating substrates level increase. And this allows a longer hemostasis and prevent the recurrence of bleeding. Another benefit is the availability of natural inhibitors of coagulation as protein C and protein S in physiologically balanced ratio, which helps to slow down the coagulation or downregulate the coagulation and might help to prevent the risk of thrombosis. So do we have enough evidence about the efficacy and safety of APCC, whether for on-demand therapy or for prophylaxis? Lots of studies. These are 5 main clinical trials that, for the sake of time, definitely we cannot go through all of them, but I am going to focus on the first 3 studies. The first one is the FIBA-NOVO7 comparative study, or what we call the FINOX study. And this FINOX study was the first and the largest multi-center randomized prospective head-to-head crossover open label study. This study aimed to assess the equivalence of the FIBA and the recombinant factor 7 in management of acute joint bleeds in patients with severe hemophilia, with hemophilia with inhibitors. And they defined the equivalence statistically as the difference in the clinical efficacy of 15% or less. And the clinical efficacy was based on the subject's evaluation of the hemostatic effect on a 4-point scale, whether it is effective, partially effective, poorly effective, or not effective. And this assessment was done at 2 hours, 6 hours, 12, 24, 36, and 48 hours after starting of treatment, but the primary endpoint of efficacy was assessed at 6 hours after treatment. It also assessed the bleeding resolution or stoppage of bleeding, as well as the pain reduction. This study design, as you can see, that each patient was randomly assigned either to the APCC or to the recombinant factor after the first joint bleed. and they were instructed to take the replacement, the bypassing agent within maximum 4 hours of the symptoms of bleeding. For the fiber, it was taken as a single dose in a dose of 75 to 100 units per kg, aiming to achieve a target of 85, whereas for the Novo7, it was 90 to 120 in 2 doses separated 2 hours apart. So 1 dose of fiber was equivalent to 2 doses of the recombinant factor 7. For subsequent heme arthrosis, each subject was crossed over to the alternate arm therapy. These are the population characteristics. I just want to highlight that the median time for the replacement for the treatment was 2 hours in both arms. The median initial dose was almost 85 for the fiber and 212 for both doses of Novo7, and the mean number of infusions was 1.3 and 2.4. A total of 96 joint bleeds were evaluated in this study. 85% were spontaneous and 15 were trauma-related, and 56% were bleeds into the same joint. So when we look to the efficacy, the number of patients who rated the fiber or the Novo7 as effective or partially effective was higher in the APCC group in 5 out of 6 points, the 2, 6, 24, 36, and 48 hours. And although both were comparable in their efficacy, yet the statistical criterion for equivalence was not met at all time points. When we look to the primary efficacy endpoint, 80% or almost 81% on the fiber group have achieved rated effective or partially effective, compared to 78% in the Novo7 group. When we come to assessment of the patients of the bleeding resolution, in the fiber group, along the 6 time points, the percent of patients reporting that the bleeding has stopped over time was higher in the fiber in comparison to the Novo7, and they were comparable, but the statistical criterion, again, of equivalence was met only in 2 points at 24 hours and at 48 hours. Using the visual analog scale to assess the pain reduction, there was significant pain reduction reaching 0 at 48 hours for the fiber group compared to 1 in the Novo7 group, although the baseline was the same for both groups at the start. And it concluded this study that despite that the statistical requirement for equivalence was not met, but both products were similarly effective in controlling the acute joint bleeds and in the pain reduction, with no reported study or study drug-related adverse events. So this is the on-demand treatment use of the fiber. What about the surgical intervention? This is the second study, which was the SURF study. And this was a non-interventional observational study that assessed 35 surgical procedures in 24 patients in 19 hemophilia treatment centers, aiming to assess the perioperative efficacy and safety of the use of fiber in surgical procedures in patients with hemophilia A or B with inhibitors, assessing the intraoperative and postoperative efficacy as well as the adverse events. These are the inclusion-exclusion criteria. I just want to highlight that the dosing recommendations in this study was 50 to 100 units immediately before surgery and then 6 to 12 hours after surgery. This was the patient's characteristics. Just want to highlight that it included pediatric patients as well. 72% of the patients with hemophilia A with inhibitors were severe, and the median inhibitor level was 416. And almost 50% of the surgical procedures were either high risk or moderate risk procedures in this study. When we look to the overall efficacy, which was rated either excellent or good, it achieved 91% overall efficacy in all procedures. As assessed post-operatively by the hematologist. Intraoperatively, the overall efficacy was 94%. It was considered to be safe and effective in controlling bleeding in hemophilia patients with inhibitors undergoing surgery. And we have to date have more than 12 studies that evaluated the efficacy of fiber in more than 250 surgical procedures with almost an efficacy of 75 to 100%. What about its use in prophylaxis? This is the ProFiber or the Profactor VIII inhibitor bypass activity. Actually, there are 3 studies, but I'm going to focus maybe on this one only. This was the first prospective randomized trial crossover multi-center trial that was conducted in 16 hemophilia treatment centers in the United States and in Europe as well. And it aimed to assess the efficacy of the fiber and its safety as prophylaxis. It addressed the question whether the use of fiber as prophylaxis could significantly reduce the total bleeding events, the joint bleeds, the target joint bleeds in patients with severe hemophilia A with inhibitors when compared to the on-demand therapy. 26 patients completed this study and were evaluable for the primary efficacy analysis. This was the inclusion and the exclusion criteria for the patients. And this is the study design. As you can see, that patients were assigned randomly or randomized into two groups to either a 6 months duration for on-demand therapy using fiber or a 6 months duration with prophylaxis on fiber. This was followed by each arm was crossed over to the alternate demand or prophylaxis and was separated by a 3 months washout for the bypassing agent. For the prophylaxis dose, it was given in 85 units per kg on 3 non-consecutive days per week. And for the on-demand, it was 85 units per kg plus or minus 15%. So 38%, by the way, were less than 21 years because being a pediatric hematologist, I'm always focusing on, of course, the efficacy and the safety of it in pediatrics as well. When we look to the primary endpoint in the reduction in the total bleeding events, there was a significant reduction of the bleeding events in the 6 months prophylaxis period by 62% compared to the on-demand 6 months period. Here, there was a mean of 13 bleeding events during the on-demand compared to only 5 in the prophylaxis period. When we look to the percent of patients who were diagnosed as good responders, as defined by more than 50% reduction in their bleeding events, 16 out of the 26 patients were considered good responders with an 84% reduction in the bleeding events during the prophylaxis, and 6 of them stopped to have any bleeding during the prophylaxis period. The other 10 patients had reduction in their bleeding events by less than 50% and 28%, and they showed 28% reduction as well in their bleeding during the prophylaxis period. Studying the effect of the crossover sequence effect, there was no significant effect in the primary outcome on the basis of the randomization sequence, and there was no carryover effect when the prophylaxis has preceded the on-demand therapy as well. What about the monthly bleeding rates? Again, a statistically significant reduction by 55%. The reduction in the joint bleeds, which represented 80% of the total bleeding episodes, again, a reduction by 61%, 72% reduction in the target joint bleeds, and 56% reduction in the monthly joint bleeds as well. What about the health-related quality of life? There was a general trend of improvement in the health quality of life. For patients who were good responders in the prophylaxis arm, they showed, again, improvement in their health-related quality of life compared to treatment, and of course, fewer days of absence, whether from school or work, attributed to the bleeding. What about the safety? There were no reported thromboembolic events, only one serious adverse event, which was related to an allergic reaction, and the 2 deaths were unrelated to the study drug. I'm almost finishing. This is the dosing guidelines according to the prescribing information of APCC. For the on-demand treatment, it's 50 to 100 units per kg every 6 to 12 hours according to the nature and the site of the bleed. For perioperative management, 50 to 100 units immediately before surgery, and then every 6 to 12 hours according to the clinical response and the bleeding. For prophylaxis, it is 85 units every other day. So in conclusion, it is an anti-inhibitor coagulation complex which is indicated for the use of hemophilia A with inhibitors, either as on-demand treatment to control bleed or for perioperative management or prophylaxis to prevent or reduce the frequency of bleed. I would recommend to have a quick look at the other 2 trials because these have addressed the value in prophylaxis as well in children, the PROOF study and the APCC in children, which confirmed the same results of the ProFiber study as well. We have 7 studies which have evaluated its use as on-demand treatment in
we have to conclude, Professor Mona.
And in 260 patients. I'm done, Dr. Mohsen, khalas. This is about the surgery. Just want to highlight that the anamnestic response in 20%, but that it does not affect the efficacy of the fiber. The overall safety, it is well established. And the thromboembolic events, I just want to highlight that it is mostly in patients who had other comorbidities or other risk factors. And of course, at least 6 to 12 hours is recommended to be separated from the antifibrinolytic agents and should not be used concomitantly with the emicizumab. And I know that we have been all thrilled by what has been happening in the field of hemophilia over the last few years. And we are still hoping for more in the next few years, especially with the ITI in Egypt, as well with the gene therapy, which I know that it doesn't have much chance for the time being in Egypt. And with this, I would like to thank you and wish you all a very good night. I know that you are all must be very exhausted, and thank you very much.
Thank you very much, Professor Mona. Actually, it is elaborated and a lot of clinical studies, comparative with the other products. And now if Professor Gary Dolan is with us, we could open the floor for the questions. Professor Gary, actually, I published with Professor Tantawi 20 years ago in hemophilia, the low dose prophylaxis. At that time, we were using actually either cryo or plasma factor 8. And actually, we don't have at that time long follow-up enough to see which patients were relapsed, but it works. Do you believe that for the low dose and the high dose, because the burden on the family, burden of the economy of the hemophilia center is like maybe up to 4 times between the low and high. So if you could concisely, which one only you choose the high protocol, not the low protocol, you should use the high protocol?
I mean, it's interesting. I mean, I think, as I say, in the UK, we use an intermediate dose and we'll go to the high dose if patients are not responding early. But you raise an interesting point, because the low dose arm in the ITI study was 50 units per kilogram 3 times a week. But I'm not aware of anybody publishing data using lower doses, because you never know. You might get a response using even lower doses of factor 8, as long as you continue it over a longer period of time. And perhaps you and your colleagues would be in a good position to examine that.
Yeah, we send it to the, I had this year the experience with 20 ITI patients with the 50 international unit per kg 3 times. And we were using bypassing agent 7A, but the last couple of patients we were using fiber since it became approved in Egypt. But of course, only if there is severe bleeding. If it is not severe bleeding, we don't use the bypassing agent. I have a few questions from Professor Khalid Eid and from Professor Mohammed Mabed. Do you believe that the protein C and protein S in the being in fiber, do you have any idea if they have any role or could help or not?
It's a good point. I don't know is the short answer. I don't know whether they are in fiber because it's part of the fractionation process. That maybe they're there by accident, or whether there's some deliberate attempt to, but I'm not sure that the dose would be, I don't know whether the content would be high enough to make a major impact on thrombogenicity of fiber.
What's the shortest time you give for patient with inhibitor? Like, do you ever give 6 months and there is complete response, or you minimum of 12 months with the intermediate dose? Yeah. And how much follow-up before you said he relapsed or not?
Good points. I think in the case I presented, one of the cases, the patient achieved tolerance in 3 to 4 months, which was very good. So they can achieve tolerance quite early. The big difficult ones are the ones who don't achieve. The big question is, how long do you keep trying? You know, if they are not showing any fall in the Bethesda titer, and they're still have a bleeding phenotype. I mean, it's one of the biggest challenges. Some people have gone on 2 years, some people go on for even longer. I mean, it's not really ITI then, it's a sort of funny halfway house. But I think by 12 months, you normally get a pretty good idea of what's going to happen.
Such cases, do you go from intermediate to high dose, or you prefer to give immune modulation? Because in our early publication, we were using some immune modulation for some patients, but in the new publication, in the new series, we don't use that. And why we don't use it? People are afraid of using either steroids or immune modulation, and I find it sometimes not very good idea. What do you believe?
Yeah, so our policy in the UK is we would escalate to the higher dose if we were not getting a response with intermediate dose. But the alternative, as you present, is you could just carry on for longer. But the ITI study finished early, so we didn't really get a chance to look at that properly. As far as immune suppression is concerned, I guess, you know, it's a comparison between an autoimmune condition or autoantibody where you would expect immunosuppression to work, and an alloantibody situation where maybe there's less chance of it working. And of course, particularly with children, people are worried about overwhelming infection. Certainly the enthusiasm for rituximab has waned in the UK with regard to ITI.
Professor Mona, do you believe that FIBA in your center will have a chance as bypassing agent? As I said to you, I use it in a couple of patients. It works well. What do you believe in your center in Cairo University, Abu Rish?
Definitely, Dr. Mohsen. I believe that it will have a chance, of course, in our center, especially that its long half-life would enable us to maybe use it parallel to the recombinant active factor 7 as well. But what we have been, as you already know as well, that we have been having also patients on emicizumab. What we are hoping is that by time we have the proper chance to counsel our patients properly and to give them the chance to choose whatever line of treatment is most suitable to their quality of life.
Razan, if you are there, do you have problems with your like women health and the inhibitor, or most of them they are acquired hemophilia? Do you believe that the carriers, the hemophilia ladies, some of them develop inhibitors or not? And what's the problem in your population in Royal Free Hospital?
Well, I so far I've only had 2 postpartum acquired hemophilia, so not great experience, and managed by hematologists rather than me, apart from stopping the postpartum hemorrhage.
Okay. I will look if there is more questions from the floor. Professor Mohammed Abdel Mohsen, the frequency of thrombotic events with FIBA and possible risk factors. Do you believe, Gary, as in population of severe hemophilia A with inhibitors, FIBA used as bypassing agent carries a specific risk for thrombosis, or you don't believe so?
Again, it's been a subject of a lot of study, and effectively the risk of thrombosis with FIBA and Novo7 is low. It does occur, but it occurs with factor VIII and other products too, and the thrombosis tends to occur during periods of intensive treatment. So I think when patients, and they're often in a surgical setting, so the risk of thrombosis is already there, and then you're correcting the coagulation defect and the patient gets thrombosis. Or the alternative situation is the patient may have underlying cardiovascular disease that perhaps the bleeding tendency protects against, and then you give them treatment for an operation and they get thrombosis that way. So I think the risk of thrombosis is low with both FIBA and Novo7.
Professor Mona, if you have question to Professor Gary, you can address it, or for Razan, since she is with us. Good chance.
Yes, please. I would like to ask Dr. Dolan, after his experience in hemophilia now, if they have any cost-effectiveness studies comparing the ITI to the emicizumab therapy now, now that you have been using it for quite some time.
Yeah, good question. I don't think that enough children have been treated with emicizumab to compare it properly. Certainly, ITI in the UK is considered cost-effective in the longer term because of the relatively high chance of success, and so their future treatment with factor VIII is overall cheaper than bypass therapy. But I think those interesting pharmacoeconomic data will be generated over time.
And do you believe that still any patient with inhibitors and there is episodic bleeding cannot be solved by emicizumab? He should receive a bypassing agent for this episodic bleeding, right?
You mean if they are on emicizumab?
Yeah.
Yeah, I think the obvious caution there is using FIBA in that situation. So I think if you are using FIBA for bleeding events on emicizumab, you have to use lower doses, and you cannot.
That's right, but what I mean is that emicizumab in inhibitor patient, if there is episodic bleeding, emicizumab will not solve the problem. You need bypassing agent.
No, you need bypass therapy to treat breakthrough bleeds on emicizumab. Yeah.
Yes. Yeah. So your last conclusion: any ITI patient, if we can treat him early, either with the low dose or intermediate according to the facility, should be treated. Do you agree for this statement?
Yes, I think that's the current consensus of opinion. There is differing opinions, but I think that's the general consensus at this time.
And the earlier treatment, the better response, you believe?
Yes.
If so, I would like to thank Takeda, FIBA, Razan, Naveen, Gary Dolan, and Professor Mona Al-Ghamrawi, and all the attendees till that late time. And I conclude this session, and we will meet on Wednesday, 24th of March. We have James Bossell from Cornell. We have a lot of speakers from Europe and States and from Egypt. Thank you very much for this nice evening. Razan, thank you very much for being with us up till now. Thank you, Gary. Thank you, Mona. Thank you, Naveen. Thank you, Khadija, and all attendees. Thanks for Takeda. Thank you very much.
Thank you all, and hope to see you soon, inshallah. Thank you.
Shukran.
Thank you, Magdi. Magdi, I didn't know you are there. If you would like to say last word.
No, it's fine. It was really interesting, the session and the views. But I concur with Dr. Jerry that even with the bypassing agents for young children, if we start ITI, this will be much more cost effective in the long term.
Thank you.
Okay. Thank you very much. And in population of hemophilia in Egypt, 6,000, and the inhibitors is 20%. So maybe we have like 1,000 patients. Wow. Not all these 1,000 patients will be on emicizumab. And if early treatment and you put them back to their status before they develop the inhibitors, and during that time, if they have severe episodic bleeding, use bypassing agent, then at the end of successful ITI, you decide to put on prophylaxis, which plasma-derived or recombinant or whatever. As Gary said, thank you very much for this afternoon session for Takeda. Thank you, Gary. Thank you, Mona, again. And thank you, Magdi, Professor Galila, Professor Naveen, Khadija, Fatma, Iman, Khalid, and Muhammad Mabed, and all of you. Thank you very much.